क्लाउड पे, ठीक है। और
हम्म,
बाकी जितना है वो जो हम अपने पास से करेंगे वो हम कर लेंगे, ठीक है। अच्छा,
बिल्कुल
इसमें अभी
बिल्कुल।
आप भी जो है वो एज पैनलिस्ट आ रहे हैं, ठीक है सर।
जी मुझे आप या तो को होस्ट करना चाह रहे हैं या पैनलिस्ट में रख लें, कोई मसला नहीं है मुझे, क्योंकि मेरा और भी सेशंस चल रहे हैं ना इस टाइम पे, सेम टाइम पे।
अच्छा, वो तो कोई इशू नहीं है,
हाँ
वो तो हम
हाँ,
देख लेते हैं,
जी जी,
ठीक है। अच्छा, इसमें अभी हम ये करते हैं कि हम वो वीडियो लाइव कर देते हैं और वो
सही
वीडियो हमारी
डन है।
चलती रहेगी। एक दफा साउंड वगैरह भी आप चेक कर लो, उसके बाद फिर
जी
आप म्यूट हो जाना। फिर जो भी
सही,
कम्युनिकेशन होगी, कोई इशू आएगा तो फिर हम अलाइन कर लेते हैं, ठीक है।
बिल्कुल 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 बिल्कुल।
एक मिनट, हम सेशन अभी सेटिंग कर लेते हैं सारी।
जी
अब वो वीडियो ना गेट्स की और जो दूसरी थी ना वो वीडियो, वो कर दो जी। अलावा तीनों को वो सही without logo। अच्छा, क्या नाम है आपका शहीर, मुझे काइंडली ना आप वो वाली लिंक भी दे दें जो अटेंडी वाला है, तो मैं प्रीव्यू भी चेक करता रहूंगा कि अटेंडी को क्या दिख रहा है। शहीर, आप हैं हमारे साथ? नहीं नहीं, म्यूट तो रहने दो। शहीर काइंडली हमें
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about
नुसरत एकदम
introduction
साउंड
of
सही है इसका।
Pakistan Endocrine Society. As you all know, diabetes is progressing
साउंड का
day
क्या
by
कह रहे हैं
day. Pakistan is at number 4, and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान की trained endocrinologists come together and they diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. First time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmad, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmad, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with the introduction of fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान की trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them
Hello.
we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you.
हेलो, आवाज आ रही है यार? मगर इसमें गूंज रही है, पिछले में नहीं गूंज रही थी।
उस हिसाब से फिर हम लोग स्टार्ट करें ना। अभी हम लोग जूम पे तो हम लाइव जाएंगे, उसमें वीडियो रन हो रही है, ठीक है? तो ताकि हमारी ऑडियंस जो जनरेट हो, जब यहाँ से आप लाइव करेंगे तो फिर हम उस हिसाब से।
इसमें ये बड़ा मसला आ रहा है, ये बहुत ज्यादा आवाज है, थोड़ा सा कम हो सकता है? कम करो जरा। किसको? अंदर पॉकेट में आ जाएगा ना। हेलो, पॉकेट में डाल दो। क्यों? तुम तो खड़े रहोगे ना उधर। हेलो, हाँ जी, ऑल फिट? कहाँ है भाई, बाकी लोग किधर हैं? पीजी खुनो नहीं हो सर, डबल फेलोशिप में कड़ी दी पीजान सर।
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of my this short video is about introduction of Balochistan chapter, Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4, and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of my this short video is about introduction of Balochistan chapter, Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4, and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects, prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects, prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान की trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान की trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of my this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of my this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan. I think we will be doing good with these fellow colleagues, and I wish them a successful program of this launch, and we will work together to move forward. Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Ibrahim Ahmed, President-elect Pakistan Endocrine Society. The purpose of this short video is about introduction of Balochistan chapter Pakistan Endocrine Society. As you all know, diabetes is progressing day by day. Pakistan is at number 4 and we had about 19 million people having this diabetes. Pakistan Endocrine Society is an umbrella जहाँ पे सारे पाकिस्तान के trained endocrinologists come together and they are serving one common purpose to fight diabetes. हम सब साथ चल रहे हैं. We were very active in KPK, Punjab, Sindh. Diabetes had two aspects: prevention aspect and management aspect. We were very good in management aspects, but in prevention, first time Pakistan Endocrine Society had started diabetes prevention programs, and for that in Balochistan, the people like our esteemed members like Naeem, Suresh, we can fight against it. Regarding this program, we are launching Pakistan Endocrine Society Balochistan chapter. In the next election, we will be having a full-fledged vice president sitting here and seeing the affairs of this Pakistan Endocrine Society. So from center, we will be giving them some tasks. They are fully capable, and inshallah, we are seeing a very good future regarding prevention of diabetes in Balochistan.
Please be seated.
I think we will be doing good with these fellow colleagues, and I wish them a successful program of this
Kindly be
launch.
seated.
Hello.
We're about to start.
We will work together to move forward. Thank you.
Assalamu alaikum. So, ladies and gentlemen, so we will formally start the today's session. So, first of all, I, Dr. Sher Zaman and Dr. Matiullah, on behalf of Pakistan Endocrine Society Balochistan chapter, welcome you all, our prestigious seniors, Professor Khurshid, which will be shortly online, and our guests from other provinces. Welcome you all for on this occasion. So, formally, we will start our session by recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا
Jazakallah. Now I would like to call upon the President of Pakistan Endocrine Society, Professor Khurshid Khan. He is one of the legends of endocrinology, and I am blessed to be his student at one point of time. And today he is joining us from Lahore, and he is one of the best endocrinologists of Lahore. Professor Khurshid Khan, thank you so much for joining us.
Bismillahirrahmanirrahim. Thank you very much for the invitation. And just give me 1 minute, please. I'm trying to just line up things in here, which should be done. Okay, great. First of all, I'm very thankful to the organizers of this event to invite me and organize such a marvelous day. Today is a great day for Pakistan Endocrine Society. As president of Pakistan Endocrine Society, I feel very, very honored, very humbled, very privileged in today, because we are going to inaugurate our Balochistan chapter. Uh, um, Pakistan Endocrine Society, way back in 2001, when we started, it was only few members from Karachi. We started as, I believe, Karachi chapter, Karachi Endocrine Club, something like this. And Alhamdulillah, since then, this society has expanded across the nation with chapters in every single corner of the country. And there was a dire need to establish something in Balochistan, which by the grace of God, we are seeing this day, that this chapter is being created, being established. And I'm going to come to the details of this chapter in just a few minutes. I see a lot of general practitioners here also, along with members of our prestigious speakers and members of our panel for this program. And I'm very thankful to all of them for sparing their time to come attend this session and physically grace this occasion when we are actually inaugurating our Balochistan chapter. General practitioners, they are very integral part of Endocrine Society. They are our associate members, and Pakistan Endocrine Society values their presence very much. And we have arranged multiple seminars, CMEs, certification courses for our general practitioners, and plan to continue the same in coming days as well. Let me give a very famous quote from John F. Kennedy, who once said that, "Ask not what your country can do for you, ask for what you can do for your country." So in that regard, I'm going to put this in the perspective of what our members here in Balochistan have done. I'm specifically referring to Dr. Naeem Khan Durrani, Dr. Suresh Kumar, Dr. Matiullah, and Dr. Sher Zaman, because these are our members who got training from different parts of Pakistan, and then they decided to go back where their roots are, serve the community where they came from. So I think this is a way of giving back to what your community, what your area, what your region has given you, and trying to give back to your place instead of just saying, okay, this is the biggest city, most hip city, I'm going to live in that city, stay in that city. So a lot of, I really commend all these members for being for taking this, playing the role of this torchbearer and be the first in Balochistan to establish a formal endocrine faculty in there. So very grateful to all these members. I'm very grateful to the speakers of today's session, Dr. Aisha Sheikh, Dr. Atif Munir, Dr. Hussein Afridi, who have come from different areas to grace this, to be part of this historic event. And I'm very grateful to our panelists, Dr. Zahir Khan, Dr. Jahanzeb Nasser, Dr. Jalaluddin, Dr. Irshad Khoso, Dr. Aisha Siddiqa, Dr. Khalid Shah, Dr. Zafrullah, Dr. Mujib Tareen, Dr. Baki Durrani, and Dr. Naila Hassan. So it's really a great feeling to be witnessing this whole thing. And so I'm very, very much humbled, very much thankful to all our members, all the faculty of Pakistan Endocrine Society, all of our executive members, all of our associate members, to get us where we are today. So PES is, when I became the president, one of the biggest thing which I realized that as you all know, being endocrinologist and being diabetologist, that diabetes is rampant in our society, and there is something which has to be done to prevent this pandemic, to decrease the disease burden. So the only way we can do, if we do some structured diabetes prevention program in this country. So Alhamdulillah, I'm very happy to share with you that that program has been already started. We have regional teams from all 4 provinces, and there are members of that prevention team from Balochistan, members as well, for part of the National Diabetes Program, NDP. That's what we are doing. As president, there's a new thing what I thought we should be doing aside from our ongoing certifications, courses, scientific sessions, philanthropic work. What I'm trying to bring more things towards the research aspect. And I thought, why PES cannot have their own journal? If American Diabetes Association, if Endocrine Society, they can have their journal, why Pakistan Endocrine Society cannot have their own journal run by editors, chief editors from PES, and with our associate members and with our collaborators. So we are going to launch a Journal of Pakistan Endocrine Society very soon. We are in the process of acquiring ISSN, which would be pretty soon. So I'm hoping maybe by midsummer, we should be able to bring out one first copy of this, but we'll see how things play out in coming weeks. But that certainly is in the works. And lastly, I would say Pakistan Endocrine Society is all about excellence. We are excellent. We are about excellence in clinical care. We are about excellence in research. We are about excellence about evidence-based medicine and scientific material. And I always say that excellence is never an accident. It is a result of high intention, sincere effort, intelligent direction, skillful execution, and the vision to see obstacles as opportunities. So with this, I will formally announce the inauguration of our Balochistan chapter. And it's really a matter of great pride and happiness for us as PES family. Thank you all very much for being part of this historic event. I'm very grateful.
Thank you so much, Professor Khurshid Khan, for your words and best wishes. So I would like to tell you about our today's program. So first we will be having our two lectures from Dr. Mohammad Naeem Khan Durrani, consultant endocrinologist, BMCH and AQUH Quetta. So he is executive member of Pakistan Endocrine Society. So our second lecture would be from Dr. Aisha Sheikh. She is a renowned consultant endocrinologist, AQUH. So she is Joint Secretary of Pakistan Endocrine Society. For these two lectures, our panel of experts would be Professor Dr. Khalid Shah, Professor and Head of Department. I would like Professor Khalid Shah to please occupy his seat. Second panel of experts would be Professor Dr. Jahanzeb Nasser. He is Head of Department, Medicine, Civil Hospital, Quetta. So our third panel of experts, Professor Dr. Baki Durrani. He is Head of Department, BMCH, Quetta. Our fourth panel of experts would be Dr. Aisha Siddiqa. She is Professor and Head of Department, Gynecology Department, Civil Hospital, Quetta. She will join us shortly. Fifth panel of experts would be Dr. Naila Hassan. She is Professor and Head of Department, Civil Hospital, Quetta. She will join us soon. So I would like Dr. Mohammad Naeem Khan Durrani to come at the stage and deliver his lecture.
पॉइंटर दे दीजिएगा। Assalamu alaikum. Hello, am I audible? So thank you very much, Dr. Matiula, for your kind introduction. I'm very thankful to the guests who are coming from all the country to attend this session in the inauguration of the Pakistan Endocrine Balochistan chapter. Can I have a pointer, please? How to change the slides? So today we will discuss the International Diabetes Association Ramzan guideline, which were first. Thank you very much. Okay. These guidelines, as we know that 20 years back there were no guideline, and the consultants and the diabetic patients were very much confused whether they have to fast or not fast. Even when I remember when I was doing the residency, we were not allowing the patient to fast, but some patients were insisting to fast instead of our advice that not to fast. Then the studies were done on these patients who fasted during the month of the Ramzan, and then subsequently a lot of studies done. The first IDF-DAR guideline was produced in 2005, then 2010, and then 2016. And now the recent guideline, the 2021 guideline, just launched 1 year back, that is 26th February 2021. So as we know that the fasting is one of the 5 pillars of the Islam, and it was revealed when the Quran Majid was revealed to the Muhammad sallallahu alaihi wasallam. And as a Muslim, we believe that the prayers, the worships we do are multiplied during the month of this Ramzan. So as we know that the prevalence of the diabetes is increasing worldwide, and in 2019 it was shown that there were 463 million people were diabetes throughout the world. And one thing which is very worrisome is that every 1 out of 2 is not aware of know that these patients are diabetes, which are making a very large figure of 322 millions. And these trends are set to be continued, and this figure will rise to about 700 million by 1945. It is a 51% rise in the prevalence of the diabetes worldwide. According to 2019 estimate, that the number of deaths linked to the diabetes and its complications are about 4.2 million people. Again, this is a very large figure, because this is a very large number. These patients are linked with the deaths. The causes of the death in these patients are due to the complications of the diabetes. Moreover, now we know that the Muslim population is increasing day by day throughout the world, and now 1.9 billion people throughout the world are Muslims. And among them, as we will discuss in the studies, in some studies 93% will try to fast, and in some 96% will fast. So if roughly about 1.6 billion patients of the diabetes will fast during this month of Ramzan. A recent survey which was involving 38,000 Muslims reported that median of 93% will fast during the month of the Ramadan. The epidemiology of diabetes and Ramzan study, that is the EPIDAR study, this was a landmark study. This was done in 2001, shown that the 78% of the type 2 patients will fast for more than 15 years during the month of the Ramzan, while 42.8% of the type 1 patient fasted during the month of the Ramzan for more than 15 days. In a more recent study, that is the CREED study, which was done in 2010, reported that 94.2 patients with type 2 was enrolled in the study who fasted for at least 15 days, and 63 fasted every day. So this is the figures of EPIDAR study, in which 78% of the type 2 patient fasted for greater than 15 days during the month of the Ramzan, and 42% of the type 1 patients fasted for more than 15 days during the month of the Ramzan. So this is the extract of the Creed study in which 94, sorry. The Creed study in which the 94% patients fasted for greater than 15 days. Among them, the orange line, which is 32.4% fasted every day, but not the whole month. But 67.6%, a large figure, fasted every day, that is the whole month of the Ramzan. Then subsequently, other studies after IDF 2016 guideline, the DAR 2016 guideline, DAR MENA study was done in the MENA region, which shown that even more patients were fasted during the month of the Ramzan. And the Diabetic Global Survey completed just in 2020. And the Osnan et al., who was the author of the DAR 16 guideline, did a meta-analysis on the available studies, that is the EPIDAR, CREED, DAR MENA, and DAR Global Survey. So what he found that the type 1 patients were, when they were initially in the EPIDAR, only 9% of the type 1 patients fasted during the month of the Ramzan. And in the DAR MENA study, 7.2, and the DAR Global study, there was a lot of type 1 patients, that is the number increased to 20% of the type 1 patient fasted during the month of the Ramzan. Then they included the other characteristics like fasting for more than 15 days or for the whole month, and the characteristics of the cardiovascular diseases among these patients in the different groups. This was the similar characteristics of the type 2 patients who fasted during the month of the Ramzan. Similarly, if you can see that there was a 78% patient fasted during the month of the type 2 patient in the EPIDAR studies, 94.2% in the CREED studies, 57.3% in the DAR MENA study, and the 61% in the DAR Global Survey. And the similar characteristics was looked for, like the neuropathy, nephropathy among the type 2 patients. So, as we know that the diabetes having some beneficial effect on the normal person, these normal effects are also observed in the diabetic patients. If we look at the lifestyle, physical and mental changes that can occur during the month of the Ramzan, in the lifestyle changes, the sleeping schedule changes. Patients who used to sleep irregularly in their routine life, they have to adapt a certain schedule pattern of sleeping. The mean plans they decide during the month of Ramzan, if they can follow that, of course it will affect their diabetes controlled after the Ramazan. And there is a very golden chance of the patients who smoke, they can quit the smoking during the month of the Ramzan. So we must encourage, if any diabetic patient who is a smoker, this is a golden opportunity for them to quit the smoking during this holy month of Ramzan. There are some physical and mental benefits of the fasting during Ramzan. There is sense of fulfillment of participating in all aspects of the Ramzan. These patients, there is improvement in the lifestyle of the patients of the diabetes, and there is improvement. The studies have shown that the patients who fast, majority of the studies shown that there is about 1 kg reduction in the reduction of their weight can occur, but this weight reduction is temporary. If the patient cannot adhere to the lifestyle changes, it can reverse after 3 to 4 months to their pre-Ramadan weight regions. Similarly, these patients participate in the Sunnah, and they good well deed during the month of the Ramzan, which is very rewarding for them. Like a lot of the patients in our Muslim society pay their zakat and fitranas and all during this month of the Ramzan, due to which the other poor community of the Muslim population can be benefited. Of course, there are some disadvantages of the Ramzan as well, like there is the sleep deprivation, which can lead to the fatigability, and there is glucose excursion, which can occur, especially in our part of the world, when we take a lot of meals during the iftar or the sahri time. It can lead to a huge excursion in the glucose level inside our body. The similar is there can be higher feeling of fear of because the patient can feel that if they can fast, they can.
Excuse me, Dr. Naeem साहब, मैं जो पीछे हमारे बच्चे बैठे हुए हैं स्टूडेंट्स, बेटा आप सबसे ये हम्बल रिक्वेस्ट है कि इतनी इम्पोर्टेंट टॉक चल रही है, आप लोग पीछे से जो डिस्टरबेंस हो रही है, इट मीन्स के हम किसी चीज में इंटरेस्टेड नहीं है. सो माय रिक्वेस्ट पीछे वालों से कि आप थोड़ा सा अगर खामोशी से सुन लें तो इट्स वेरी बेनिफिशियल फॉर ऑल ऑफ अस. थैंक यू वेरी मच.
Thank you, madam. So there is a short term of anxiety can occur during the month of the Ramzan, especially in our part of the world. When I was doing my internship in the surgical ward, there was a lot of trauma cases were occurring during the month of the Ramzan. So if we should keep these things balanced during the month of the Ramzan. So what are the risks if we fast during the Ramzan? The patient can having a hypoglycemia. These patients can suffer from the hyperglycemia, dehydration, and thrombosis. And not to forget, these patients are prone to the diabetic ketoacidosis can occur, especially in the type 1 patients, but the type 2 patients can also suffer this diabetic ketoacidosis, somewhat rare than as compared to the type 2 patients. The EPIDAR studies recorded the highest number of the hypoglycemia in their study in the type 1 or type 2 during the month of Ramzan. When they compared before the Ramzan, there was a 4.7-fold and 7.5-fold increase in the hypoglycemic event, respectively, in type 2 and type 1 patients. The lower figures were of hypoglycemia of 8.8 were observed in the CREED study. The reason for this low event of hypoglycemia was that some of these patients received the pre-Ramadan education and the precautions and the meal plans, which led to the somewhat less number of hypoglycemia, and this was done in the Europe. In another study, and the duration, the rate of the decay was increased during the month and the subsequent month of Ramzan, that is Shawwal, as compared to the pre-Ramzan group. So in 2016, Dahar guideline, they had some traffic lights. Through these traffic lights, they characterize the diabetic patients who are at more risk or less risk. Like in the red light, the category was very high risk group, and the category 2 was high risk, and the green light was the moderate or low risk group. It was slightly easier to remember, but now they have changed this system, which we will discuss in the subsequent slide. In the highest group, these were the patients with the comorbidities like ischemic heart patients with unstable ischemic heart disease like MI, end-stage renal diseases, poorly controlled diabetic patients on insulin or on medications. And in the low risk categories were type 2 diabetic patients with well-controlled diabetes on multiple doses of insulin with well-controlled diabetes. And in the low risk categories were the patients who were less likely to having to suffer from the hypoglycemia and hyperglycemia were the patient who are on the medications which can cause less hypoglycemia, like the metformin groups, which is euglycemic medications, the pioglitazone group like the Piozer and other like the SGLT2 inhibitors. But sorry, I think I have missed the slide. It's a fine. This is the 2021, the similar risk categorization guideline, but they have made things somewhat confusing for me and for I think for all. They have now applied the scoring system for the different categories. Like if you look, the type 1 patient, they given the 1 score, and the presence of hypoglycemia, they scored different among the different categories of the hypoglycemia, and this time they included the HbA1c criteria and scored among them according to their HbA1c level, and the type of the treatment was included in this, like the multiple daily doses of insulin and glibenclamide. And this time they have also included in this risk categories the monitoring of the self-monitoring of blood glucose level. So when the patient comes, you can look for, you can assess whether this patient is checking his blood glucose level regularly at home or not. If he is checking regularly at home, less score was given. If it is not checking, he will follow this. Less checking in the Ramzan can lead to the hypoglycemia. So it was also given at some point. And there was also the acute complications and the end stage renal diseases. I will discuss, I will put some light on the pregnancy. In the pregnancy, they have given the 6.5 score. But if you can, don't be confused, and you can get this calculator in the app store. This is available. You can download, and you can use in the clinic and score the patient. And you can score if the patient is 0 to 3 into low grade, and score 3.5 to 6 is the moderate risk group, and the score greater than 6 is kept in the high risk group. So what is the recommendation in this group? The individuals who are at high risk group, they should not fast, but as in our cultural point of view, the patients are suffering from the end stage renal disease, unstable MI. They are still insisting on that Dr. Sahab, I will fast anyhow. What happens, because I will not leave the fasting as I'm fasting throughout the life. I cannot quit the fasting during the month. If they are insisting on that, then you should give them the proper education, which will follow, which we will discuss later. And similar is that there are other groups, are those that are at moderate risk. They are advised not to fast, and those at low risk are able to fast. Initially, these categories in the very high risk group, they were advised they must not fast. This is new. And in the moderate risk group, it was the 2016 guideline was saying that they should not fast, but now they have changed this terminologies to how they have relaxed the terminologies for them. So irrespective of the risk categories the patient is falling in, you must educate them before the Ramzan, because as I discussed that a lot of the patients will say that they will fast anyhow. So you will provide them Ramadan focused education. The pre-Ramadan medical assessment, you should look for, especially for the hypoglycemia unawareness in these patients. And others are the following, you will suggest them the LD diet. You should give them the diet plan according to the Ramzan, and frequent self-monitoring of blood glucose. You must recommend them to do the frequent subcutaneous blood glucose monitoring. And we must modify their medications, which will later Dr. Hussein Afridi, who came from KPK, will discuss how to modify the medication. So I will not go in detail. And these patients should be able to, you should educate them how to break the fast, which we will discuss later. So there are some medico-religious aspect of the diabetes as well. Like the Holy Quran says that, you believe fasting is prescribed to you as it was prescribed to you before, but if any one of you is ill or traveling, then he is exempted from the fast. But it must be ensured to them that if due to the medical point of view, they are not able to fast, they are rewarded same as patients who are fasting during the month of the Ramzan. And the Quran Majid says that do not put your harm into the danger. And similar is in the hadith that you have right on your body, and your Allah has right on your body, but you have a right on your body. So then the medico-religious expects the ulama and the healthcare professionals, especially the patient, the doctors who are concerned with the diabetes, they made a consensus categorization and recommendation for the fasting, like the low risk group. In the medical recommendation, the fasting is safe. In the religious recommendation, fasting is obligatory. Advice not to fast is not allowed unless other medical conditions can, if existed with them, they can not fast during the month of the Ramzan. In the moderate risk group, the fasting, the safety of the fasting is uncertain. And in the religious recommendation for the moderate risk is that fasting is preferred, but you may look for your healthcare professional whether he is allowing you to or not to fast. In the high risk group patient, the fasting is probably unsafe. And in the medico-religious aspect, they advise against fasting in the religion in this category as well. In the bottom, you can see that the pregnant and the breastfeeding women who have the right not to fast regardless of whether they're having a diabetes or not. So pregnant ladies have a right not to fast even if they do not have the diabetes. The pre-Ramadan education is very important. Usually it should be done 4 to 8 weeks before the month of the Ramadan. I will ask some colleagues, how much of you have asked your patients who visited in your clinic that whether you will fast or not? Can you please raise your hands? I'm seeing very few hands here, roughly 20%, I can say. So let's see what the guidelines are. It is the cornerstone of the Ramadan diabetes management is the patient education. Studies have shown that pre-Ramadan counseling reduces the risk of incidence of hypoglycemia. Pre-Ramadan education provide a platform to remind patients about the importance of diet, exercise, and regulate the glucose monitoring essential to avoid the complications, while reassuring them that checking blood sugar during the period of fasting do not validate your fast, because a lot of patients are concerned that whether if I will check my sugars, my fasting will be invalidated. So these patients can check their blood glucose level when they are fasting, and it doesn't validate their fast. In the EPIDAR study demonstrated that only around 2/3 of the patients with diabetes received recommendation from their healthcare professionals regarding fasting. In the CREET studies, 96% of the physician provided advice to their patient during the Ramzan, although only 63% of the patient used the guideline at that time which was available. But as there was more number of patients were received the advice from the healthcare professionals, although they do not follow the guideline, and we know that the hypoglycemia risks were very low in these patients. And the READ program was associated with the weight loss during the month of the Ramzan. So this was a meta-analysis done in 2020 of the different studies in which they compared the weight. If you can see, weight reduction was significantly improved in a lot of the studies, but you can see that in some studies the weight was increased in spite of the fasting during the Ramzan. And the reason for this weight gain, which we can understand, is due to the dietary pattern that they follow. They take a lot of iftar when they break the fast, they take a lot of the calories, which can lead to weight gain in these patients. And similarly, the BMI was significantly improved in a lot of the studies, and the HbA1c level was reduced significantly in the patients who fasting that after the month of the Ramzan as compared to before the Ramzan, and the fasting blood glucose level was also significantly improved in a lot of the studies when they fast as compared to before Ramzan. So the objective of the Ramzan focused education is to aware the risk associated with the diabetes, and we must make strategies to minimize them. Education should be simple, engaging, and it should be delivered by a well-trained person, and the cultural sensitivity should be kept in the mind, because different cultures, different dietary patterns they are taking. You can advise dietary pattern or cultural dietary pattern to according to their culture values. In studied Ramzan focused education program have been successful in patients with diabetes to maintain and improve glycemic control during and after month of the Ramzan. This was the GED et al. Study, which was done in 2020. It showed a significant reduction of the HbA1c before the Ramzan as compared to after the Ramzan. So who should be the target of the Ramzan focused education? These should be healthcare professionals, because a lot of them, they are dealing with the diabetic patients, which were not including the general practitioners, but the patients or other physicians like the nephrologist, the cardiologist. They all can see these patients in their clinic and advise according to them. And other are people with the diabetes, which is the important one, and the general public is also important, that because in some part of the world, if someone is not fasting, people can bully them. So we must also educate the general population as well. So very important during the month of the Ramzan is whether when you are fasting, when to break your fast. This, if the patient is fasting, if his blood sugars level drops less than 70, he should break the fast. This is the recommendation. Someone is saying that if Dr. Saab, if I'm very near to the iftar and my blood sugars level are less than 70, he should recheck the blood sugar level. But if he is developing the symptoms like hunger and decrease in the GCS, he should not wait for, even if the minute is remaining, he should break the fast. And others are the blood, if the blood glucose level increases greater than 300 milligrams, he should fast, he should break the fast. But in this, if the blood sugars are greater than 300, you can individualize the planning of breaking the fast according to the individual. Like if the patient is very near to the iftar, his sugars are 300, he having no symptoms of hyperglycemia like thirst, dehydration, then he can continue with the fasting. But if he having the symptoms of dehydration like decreased GSS, he should break this fast. Other is the symptoms of hypoglycemia, which are mentioned here. I will not go in detail, and the symptoms of hyperglycemia. Self-monitoring of the blood glucose is very important during the month of the Ramzan. There is a 7-point of guide for the Ramzan, 7-point guide for checking blood glucose during the month of the Ramzan. These are include checking your blood glucose level before the iftar, 2 hours after the iftars, in the midday like 12 to 1 p.m. in the evening, if you in the evening time, that is 4 to 5 p.m. just before the iftar, and just after the 2 hours after the iftar. And the 7-point is that whenever you experience the symptoms, you must check your blood glucose level and continue. And if your blood glucose level are low, you can break the fast according to the guidelines. The dietary pattern during the month of the Ramzan is very important, as we do not have a dietitian in this course. So you can individualize your diet plan, but don't worry if we do not have a dietitian with us. The IDF DAR 2021 guidelines are for the diet are available on the App Store as well, and the app name for this is Dar Safa. You can download this and advise the patient to download this app and adapt their diet plan according to that app, in which the different regions of the world are included, in which Pakistan is also included. So if the patients who is fasting during the month of the Ramzan, if we are planning to maintain the weight, we can take these calories, the calories which can maintain the weight. And if the patient is planning to lose weight, he can take some less calories. This is a typical Ramzan plate which we take. Okay, and thank you very much.
Thank you so much, Dr. Naeem. It was very comprehensive talk on diabetes and Ramzan. Thank you so much, the audience. We have a house full in Balochistan, welcoming Pakistan Endocrine Society, all 3 provinces. So I just introduced Dr. Aisha Siddiqa, who is the counselor of CPSP Balochistan Center, and she is renowned gynecologist and head of Department of Civil Gynae Department. We also have 3 esteemed professors of medicine, Professor Khalid Shah, Professor Baki Durrani, Professor Janzeb Nasser. They are the panelists, and Professor Naila Ehsan is also another panelist. Now I would like to call upon the Dr. Aisha Sheikh, who is consultant endocrinologist, AKUH. She is the joint secretary of Pakistan Endocrine Society and ex-vice president of Sindh chapter, Pakistan Endocrine Society. She has been our mentor. She is one of the best endocrinologists of Karachi. Thank you so much, madam, for joining us. Thank you so much.
Assalamu alaikum, everyone. So, Bismillahirrahmanirrahim, Assalatu wassalamu ala khataman nabiyyin. Can you hear me? And can we have some quiet, please, at the back, please? We are all here to learn something, okay? So I'm really grateful to all the expert panelists over here, all the audience. And this is a great day for Pakistan Endocrine Society that we are launching the Balochistan chapter of Pakistan Endocrine Society. And I'm grateful to Dr. Naeem Khan Durrani and his team for inviting me for this talk. So in next 20 to 22 minutes, I'd like to discuss about hyperglycemia and pregnancy. So this is my disclosure statement. So how do we classify hyperglycemia and pregnancy? Remember, a woman who is pregnant with hyperglycemia can either be having a pre-existing type 1 or type 2 diabetes, women who are already diagnosed with diabetes, or she could be detected to have hyperglycemia and pregnancy through routine screening test. And through that, she will be either classified as having gestational diabetes mellitus, or will be classified as having overt diabetes mellitus in pregnancy. And I'll give you the thresholds of these diagnoses in next slides. So if you look at the IDF 2019 atlas, this shows that in the year of 2019, some 20 million live births were affected by some degree of hyperglycemia. And out of these, almost 84% were due to GDM cases, and the rest were either due to hyperglycemia, over diabetes mellitus in pregnancy, or due to pre-existing diabetes mellitus in pregnancy. This is our data from our own institute. Over more than a decade, you can see that the prevalence of GDM has risen remarkably. So somewhere in 2011, we switched to the IADPSG criteria, and most of the obstetricians were using universal screening. And right now it's around 18% GDM prevalence in our patients. And similar rates have been shown by our colleagues from Indus Health Network, where they're using the IDA-PSG criteria and universal screening. So what is the pathophysiology and why diabetes occurs in pregnancy? So you can see that the placental hormones have actually got diabetogenic effect, and the strongest being the human placental lactogen. And you can see in the right-hand side of this slide that the human placental lactogen concentrations increase drastically after 20 weeks of gestation. And this is the time when most of the GDMs will be discovered on screening. So the commonest cause of GDM is mainly a background of insulin resistance and our beta cell dysfunction that presents as GDM. But remember, some of the women can be having the autoimmune beta cell dysfunction. So a type 1 diabetes mellitus presenting for the first time during pregnancy, or there could be the rare monogenic diabetes that you can come across during pregnancy. So why do we worry about hyperglycemia and why we're talking about this? You can see that hyperglycemia in pregnancy leads to maternal and fetal neonatal complications. In the mother, there is a high risk of preeclampsia, and because of fetal macrosomia and polyhydramnios, there could be a higher chance of induction of labor or operative deliveries. In the baby, in the offspring, you can see that the embryo which is exposed to higher glycemia during early gestation is at high risk of CNS and cardiovascular anomalies, and similarly high risk of LGA babies and macrosomia. At neonatal level, after delivery, there's a high risk of neonatal hypoglycemia and respiratory distress syndrome, among other complications. And the story does not end at the time of delivery. Both these, the mother and the offspring is at a high risk of obesity and diabetes in later life. So the other question is whether if we manage this hyperglycemia, the mild hyperglycemia of GDM, will we be able to improve the maternal and neonatal outcomes? So this is a meta-analysis of studies, different studies, and you can see that specifically looking at outcomes like large for gestational age babies, macrosomia and shoulder dystocia, comparing if you did some intervention in terms of medical nutrition therapy, or pharmacotherapy compared to no intervention, intervention actually favored these outcomes. So how will you screen for GDMs? We have our esteemed colleagues from our OPS and Gynae over here. And you know that all pregnant women who do not have, so you will exclude women who already have diabetes or pre-diabetes, because these women will go into already hyperglycemic pregnancy care pathway. All the rest of the pregnant women, which is a vast majority, needs to be screened. And that screening should be done through an oral glucose tolerance test, a one-step strategy, because our population is at a high risk of GDM. The two-step strategy is not a very cost-effective option for our population. So the recommendation is that you should screen them at the first antenatal visit. And this is actually meant to discover any undiagnosed diabetes. So a woman might be having diabetes or pre-diabetes and was not aware of her glycemic intolerance status. And if this first antenatal visit's OGDT is normal, then you will rescreen her at 24 to 28 weeks of gestation. And this is the diagnostic criteria. So coming from the IAD-PSG criteria, which is universally applicable and has been adopted by WHO and IDF as well, you can see that these are the thresholds on 75-gram glucose tolerance test. So a fasting of 92, a 1 hour value of 180, 2 hour value of 153. If any of these values are achieved, if the patient has any value that is meeting or exceeding these thresholds, you will label her as having GDM. Remember, HbA1c is not something that can be utilized for diagnosing GDM. However, when we talk about over-diabetes mellitus in pregnancy, so over-diabetes mellitus in pregnancy would be those women whose glycemic thresholds are meeting those cutoffs which are used to diagnose diabetes in a non-pregnant adult. So if a woman is having that kind of threshold, you will label her as over-diabetes mellitus in pregnancy. And that has importance because this woman might be having diabetes before she got pregnant and she was not knowing about her glycemic status, and she needs more comprehensive and vigilant care during pregnancy. In high-risk cases, HbA1c of 6.5% as used in non-pregnant population can be used for diagnosing over diabetes mellitus, keeping in mind the high prevalence of anemia and hemoglobinopathies in our population. Similarly, the fact that we do not have standardized HbA1c assays across Pakistan. So there are certain caveats. So what about women who already have PCOS and are on metformin for miscarriage prevention? For these women, you can either get a fasting plasma glucose on its own while she is on metformin, or you can get a glucose series, which will, and then when once her metformin can be safely stopped after first trimester is over, then you can get her OGTT after 1 week of stopping metformin. And if that OGTT is normal, then you can re-screen her with another OGTT at around 28 weeks of gestation. There would be a certain subset of women who will not be able to tolerate the 75-gram glucose load and might be vomiting. For them, just getting a glucose series is a wise decision. So you can get their fasting plasma glucose and all 2-hour postprandial values. What about a woman who already had an OGTT, which was normal at 24 to 28 weeks of gestation, and now she is, her third trimester fetal growth scans are showing fetal macrosomia or polyhydramnias? In those circumstances, it's advisable to get a glucose series or ask her to monitor her blood glucose more often, and just to discover whether there is a glycemic abnormality over there. So another important subject is actually for our physicians who are managing diabetes. Preconception care of a woman with pre-existing diabetes is very important. So because poor glycemic control can lead to higher miscarriages and higher risk of congenital malformations. And remember, the window of opportunity is very narrow over here. So something like 3 weeks to 6 weeks post-ovulation, major CNS and cardiovascular defects can occur in a woman with poor glycemia. So it is recommended that the woman should be having an HbA1c of less than 7% or maybe around 6% ideally, if that can be achieved without putting her at a high risk of hypoglycemia, and folic acid supplementation starting at least 3 months prior to pregnancy. So it is important that you should be discussing plans of pregnancy with your female patients who are in the reproductive age window, and optimize their glycemic control, put her on safe medications which are safe to be taken during pregnancy. Similarly, if she is overweight and obese, she should be counseled for weight reduction. And women with pre-existing diabetes should undergo screening for complications, including nephropathy and retinopathy. And if any are found, those should be stabilized before she is allowed to conceive, because you want to avoid something like this retina, which is already having early diabetic retinopathy changes, progressing to sight-threatening retinopathy that can easily occur with the hormonal changes that are occurring during pregnancy in a woman who already has pre-existing retinopathy. So remember, all your ACE inhibitors, ARBs, statins, and fibrates, which you use very often in your non-pregnant population, are contraindicated during pregnancy. And these women should be on safer medications during pregnancy and in the preconception period as well, while they're planning to conceive. So how will you manage GDMs? You know that medical nutrition therapy, exercise, and self-monitoring of blood glucose is very important in the management part. And medical nutrition therapy should be given in a way that there's an appropriate weight gain. Low glycemic index carbohydrates are recommended, so you will stop all refined and simple carbohydrates, limit their saturated fat intake as well, but allow them to take other fats and proteins. Restrict carbohydrates, but do not eliminate carbohydrates, because these are important during pregnancy. So at least 175 grams per day of carbs are needed. And the meals should be distributed throughout the day into 3 meals, main meals, and 2 to 4 snacks. She should be having a bedtime snack as well. She should avoid fast and feasts, and should avoid sweet treats as well. Similarly, exercise is important, because walking being a simple exercise can be easily undertaken by a pregnant woman, unless there is an obstetric contraindication where you can advise her to do upper body ergometric exercises. But it is important that she should not be starting any new vigorous activity during pregnancy. These are the recommended glycemic targets in the preconception period and during pregnancy. Remember, these thresholds are for pregnancy because through these thresholds, you will be able to avoid all those fetal and maternal and neonatal complications. So fasting plasma glucose below 92, you can order her to take either a 1 hour after every meal or a 2 hour after every meal. For 1 hour threshold is 140 milligram, below 140, and for 2 hours less than 120 milligram. So this SMBGs, remember, there isn't a one size fit all approach for SMBGs. You have to individualize SMBGs. So that will be based upon the diagnosis, whether she's having GDM or type 2 diabetes or type 1 diabetes, because women with type 1 diabetes will need more often monitoring as compared to a GDM who is controlled only on medical nutrition therapy. Similarly, stage of pregnancy will need more frequent monitoring during first and third trimester. If she is hypoglycemia unaware, again, you will need more frequent monitoring. And if there's evidence of polyhydramnios or fetal macrosomia, then more monitoring is required. Pharmacotherapy will come into play when medical nutrition therapy alone is unable to control within the glycemic targets, or there's lack of expected weight gain, or if patients are consistently hungry, or if the fetal abdominal circumference is showing large for gestational age fetus or macrosomia. So you can see that if a woman is having over diabetes mellitus in pregnancy, you have to initiate pharmacotherapy and medical nutrition therapy and exercise both together, because this is really poor glycemic levels which need to be controlled quite early. For women who have lesser degree of hyperglycemia, you can give medical nutrition therapy at least a week or more and see whether her glycemic control improves. Remember that almost 40 to 50% of women can be controlled on medical nutrition therapy and exercise alone who are having GDM. But that is not true for all your over diabetes mellitus in pregnancy. About pharmacotherapy, we all know that insulin is the gold standard, but over last more than a decade, we have data on metformin as well. But remember, if a woman is having over diabetes mellitus in pregnancy, or her fasting plasma glucose at diagnosis was more than 110, this is the woman who will actually require insulin. So for over diabetes mellitus, either you can initiate both metformin and insulin alongside, or only insulin to begin with, and you can add metformin if you're finding that the woman is requiring very high doses of insulin. For more than for this moderate degree of hyperglycemia, you can maybe opt for metformin to control her postprandials and basal insulin to control her fasting plasma glucose. So about insulin, for basal control, NPH insulin and determinant insulin works wonderfully well, and these are approved for use in pregnancy. For somebody who is having type 1 diabetes and was already on glargine, you can continue glargine during pregnancy. For prandial control and bolus insulin, regular insulin, aspart and lispro are approved. Remember, we do not have data on glulisine use in pregnancy, so that should be avoided. So if the post-MEAs are high in a woman with GDM, all you can do is to start bolus insulin at a rate of 0.1 to 0.15 unit per kg per meal. And if the fasting plasma glucose are keeping high, you can give her basal insulin through a 0.1 to 0.2 unit per kg per day dose. And then remember, whenever you're starting insulin to a patient, teach her insulin techniques to insulin storage, SMBG charting, and how to utilize that SMBG chart to self-adjust insulin doses if she's wise enough. Otherwise, maybe you can call her very frequently and adjust her insulin doses according to the SMBGs. Hypoglycemia management and recognition is very important whenever you are giving insulin treatment. And on follow-ups, make it a habit to look at insulin injection sites, because there could be lipohypertrophy that leads to problems with insulin absorption. During pregnancy, the insulin requirements increase remarkably. So beyond 24 weeks of gestation, you can see in this slide that insulin requirements go exponentially high, reaching a plateau at around 35 weeks, and after which it can stabilize. So this is the time between 24 to 35 weeks when your patients will require dose escalations very frequently, and make it a habit to teach them how to utilize their SMBG chart for making those escalations. Similarly, in well-controlled women with type 1 diabetes, the early gestation between 8 to 14 weeks of gestation, which is a period of heightened insulin sensitivity, their insulin requirements might go a little low, but after 14 weeks, their insulin requirements keep on increasing. So around 34 weeks and 35 weeks, these plateau or may reduce by almost 10% of daily dose requirements. About oral agents, we know that we have data on glibenclamide use and metformin use during pregnancy, published data. And this is from a meta-analysis which showed that women with GDM requiring drug treatment, glibenclamide is clearly inferior to both insulin and metformin. With metformin, plus insulin required performs slightly better than insulin alone in GDMs. Recently, a major trial on type 2 diabetes mellitus and metformin use has been published and has shown that metformin combined with insulin works better than insulin alone in type 2 diabetes pregnant women. Monitoring the baby, you will need some extra monitorings of these fetuses because you want to look at their echocardiograph, especially for women who have pre-gestational diabetes mellitus, and growth scans are very important. Remember that more vigilance is required in the first and third trimester, and role of aspirin in low dose is there for preeclampsia prevention, which you will start at a 75 to 150 milligram dose before 16 weeks of gestation. Hypoglycemias during mid to late third trimester may be an early sign of placental insufficiency, and that requires close fetal monitoring and biophysical profiles. During labor, again, insulin, if needed, insulin infusion have to be administered. And during labor, the glycemic control has to be maintained somewhere between 70 to 126 milligram per DL. Otherwise, there would be a risk of neonatal hypoglycemia. So in the postpartum period, most of the GDMs will have normal blood glucose postpartum, and they will not require any treatment or medical nutrition therapy. But your type 2 diabetes women would require a reduction or omission of insulin doses, and you can continue metformin and even glibenclamide during breastfeeding as well. For your type 1s, during lactation, the insulin requirements reduce as compared to their non-pregnant insulin requirements. So you start with something like 0.3 unit per kg per day for your type 1s who are lactating. Again, contraception is important for all these women because you will like them to have a proper planning for next pregnancy. So a good contraceptive advice is needed. For your GDMs, you will like them to have an OGDT 6 to 12 weeks post-delivery. And if that OGDT is normal, then you will need to repeat that OGDT every 3 years or before her next pregnancy. And if she has got type 2 diabetes or pre-diabetes, then it's important that you refer these women to physicians with diabetologists, endocrinologists for management and prevention of diabetes strategies. Remember, type 2 diabetes mellitus risk increases after GDM. So after more than 5 years, almost 20% of women have developed type 2 diabetes. And GDM predicts a 2 times higher risk of cardiovascular disease as well. And this is irrespective of incident diabetes. So she might not have developed diabetes post GDM, but her risk of cardiovascular disease is higher. Similarly, so we talk about glycemia in pregnancy, but there is a heightened risk of enhanced cardiovascular risk factors underlying as well. And so pregnancy actually offers a cost-effective window of opportunity to provide maternal care services to reduce traditional perinatal and maternal morbidity and mortality indicators. But in addition, it identifies high-risk women and addresses intergenerational prevention of non-communicable diseases such as diabetes, hypertension, cardiovascular disease, and stroke. So to conclude my presentation, this is our GDM selfies recommendations present at JPMA, a very comprehensive document that will be really helpful to our audience for managing hyperglycemia in pregnancy. And this is the take-home message. Hyperglycemia in pregnancy is common and is associated with significant maternal, perinatal morbidity and mortality. And preconception care of women with pre-existing diabetes is important. And it is important for all our physician colleagues. You should discuss their pregnancy plans and manage preconception care to them before she lands up in pregnancy. Universal screening with one-step OGDT for GDM is recommended. Offer medical nutrition therapy, exercise, and SMBGs to all women with GDM, and offer pharmacological treatment when desired glycemic targets are not achieved on medical nutrition therapy and exercise alone. manage hyperglycemia in pregnancy in shared care settings. So you have got endocrinologists in Balochistan now. Try to have GDM clinics where your endocrine colleagues can go and do clinics, combined clinics, and that will be really helpful and will help building skills in both specialties as well. And postpartum diabetes risk reduction strategies are important for all post-GDMs. So do not forget them, that they are at high risk of diabetes and cardiovascular disease. So with this, I come to the conclusion of my presentation, and thank you very much for your presence.
Thank you so much, madam. This was a wonderful presentation on gestational and pre-gestational diabetes. So we had two presentations. One was on diabetes and Ramsan guidelines, and the second presentation was on gestational and pre-gestational diabetes. I will first be asking two questions from the audience, and whoever gives the answer will get the prize. And after that, we will go to the panelists. So the first question that I have is from Dr. Naeem's presentation. Anyone who wants to answer, just raise the hand. The first question will be how to categorize diabetes and Ramsan, the diabetic patients who are going to fast. How to categorize them into three groups, and then what risk factors would you ask from that patient, and what things will determine that what patients can fast, should not fast, must not fast? Anyone who wants to answer? Anyone? कौन से तीन कैटेगरीज में हम डिवाइड करते हैं डायबिटिक्स को फास्ट करने वाले, और उनमें कौन फास्ट कर सकते हैं ग्रीन लाइट, कौन फास्ट नहीं करना चाहिए शुड नॉट फास्ट, बट अगर कर रहे हैं तो उनको फिर थोड़ा सा रिजीम मॉडिफाई करना चाहिए, एंड किन लोगों को बिल्कुल फास्ट नहीं करना चाहिए, मस्ट नॉट फास्ट, रेड कैटेगरी? सारे आंसर्स चाहिए. कैन यू ट्राई? कैन वी हैव अ माइक? माइक दे दे, कोशिश करें. सो
अस्सलाम वालेकुम एवरीवन. पहले कैटेगराइज करना चाहूँगी हाई रिस्क, मॉडरेट रिस्क, और फिर उसके बाद सेफ, मतलब लो रिस्क होते हैं. तो हाई रिस्क में वो होता है जिनकी जो स्कोर होता है वो 6 से ज़्यादा होता है, और जो क्या कहते हैं मॉडरेट रिस्क होता है 3.5 से 6 के अंडर आता है. जो लो रिस्क होता है वो 0 to 3 तक आता है. तो जो लो रिस्क कहते हैं वो सेफली अंडर द गाइडलाइंस, वो मेरी डॉक्टर के गाइडलाइंस के अंडर वो कर सकते हैं फास्टिंग. मॉडरेट रिस्क वाले भी अंडर द गाइडलाइंस कर, पर जो हाई रिस्क है वो बिल्कुल नहीं कर सकते.
ये तो पहला सवाल था, फिर मैंने थोड़ा सा और डिटेल में पूछा था. दिस वाज अकॉर्डिंग टू द 2021 गाइडलाइंस, जो आपने स्कोरिंग करके हमें बता दिया. आप ये कर सकते हो बिल्कुल, आप ऐप इसके आ गए हैं बहुत सारे, और आप गूगल कर सकते हो, बट थोड़ा सा कॉन्सेप्ट ऑडियंस को दे दे. ये क्यों हम कह रहे हैं कि कोई फास्ट कर सकता है, कोई नहीं कर सकता है, किसी को करना चाहिए?
क्योंकि उसके रिस्क जो होते हैं हमारे पास, वो
क्या रिस्क है? थोड़ा सा मोटा मोटा मुझे बता दे.
हाइपरग्लाइसेमिक या हाइपोग्लाइसेमिक हो सकते हैं पहले, फिर उसके बाद
हाइपरग्लाइसेमिक मींस?
हाइपरग्लाइसेमिक मतलब उनको भूख,
सिवियर हाइपरग्लाइसेमिक ना, हाइपर तो सब हाइपर है.
मोर देन 300 मिलीग्राम,
मोर देन 300 हो रहे हो, बार बार HbA1c ज्यादा हो, कॉम्प्लिकेशंस हो,
तो,
और
उसके बाद हाइपोग्लाइसेमिक हो लेस देन 70 मिलीग्राम पर डेसीलीटर.
थोड़ा क्वांटिफाई करके बता ना. हाइपोग्लाइसीमिया बार बार हो रहा हो, सिवियर हो रहा हो, हॉस्पिटलाइज हो रहा हो, या अनअवेयरनेस हो, इन सब के कुछ स्कोरिंग्स है. जैसे अनअवेयरनेस की बहुत ज्यादा स्कोर है, अकेले उसके 6 स्कोर है. ठीक है जी, ये तो एक बात हो गई, हाइपो और हाइपर. और कुछ कॉम्प्लिकेशंस ऐसे हैं,
और इसके
ये सब सुन ले क्योंकि एक रिवाइज हो जाएगा इसमें.
थ्रोम्बोसिस, और एक और था जो मुझे भूल गया.
थ्रोम्बोसिस हो रहा हो. क्या कॉम्प्लिकेशंस होते हैं डायबिटीज के? माइक्रो एंड मैक्रो.
डायबिटिक कीटोसिडोसिस में भी अगर पेशेंट,
वेरी गुड, वो तो एक्यूट है ना. पिछले 3 महीनों में डायबिटिक कीटोसिडोसिस हो गया हो. माइक्रोवैस्कुलर कॉम्प्लिकेशंस कौन कौन से हैं? नेफ्रोपैथी, जो कि CKD है, तो उनको स्टेज 2 या 3 का CKD होगा तो स्कोर थोड़ा सा कम होगा, मॉडरेट होगा. और अगर किसी को डायलिसिस पे है, स्टेज 4 और 5 है, तो ज्यादा होगा. तो ऐसे हम कैटेगराइज करते पेशेंट को, सिर्फ शुगर के बेसिस पे नहीं करते. उसके कितने कॉम्प्लिकेशंस है, कितना वो पेशेंट जो है वो ड्यूरिंग फास्ट हाइपो में जाने के चांसेस, और हाइपर में और डिहाइड्रेशन थ्रोम्बोसिस में जाने के चांसेस है. इस हिसाब से हम इन कैटेगरीज में डिवाइड करते हैं. चलिए, सवाल दुरुस्त माना जाता है आपका. सेकंड क्वेश्चन पे मैं जाता हूं. आप अपना नाम बता दें इनको. Second question is from Dr. Aisha Sheikh's presentation, and specially request to gynae PGs or medicine to answer this question. According to the IADPSG guidelines, किसी और का नहीं पूछ रहा हूं, और यही फॉलो हो रहा है by the WHO, by the SEFIs. SEFIs की खुद जो है वो डॉक्टर आयशा शेख बहुत इंपॉर्टेंट मेंबर है एंड रिप्रेजेंटेटिव है. So SEFIs means South Asian Federation for Endocrine Societies. उनकी जो गाइडलाइंस है वो फॉलो करते हैं IADPSG. According to that, आप कैसे GDM या प्री जेस्टेशनल डायबिटीज या GDM को आप कैसे डायग्नोज करते हो? क्राइटेरिया क्या है उसमें? फास्टिंग कितना होना चाहिए, पोस्ट 1 आवर, पोस्ट 2 आवर कितना होना चाहिए, और कितना ग्लूकोज देते हो? सारे आंसर्स चाहिए. हाँ, सब बातें आप बताना चाह रहे हो, सारे पता है जी? उनको बता.
अस्सलाम वालेकुम. अगर वैसे वो 75 ग्राम देते हैं,
75 ग्राम देते हैं,
फिर उसके बाद 2 आवर्स के बाद मॉनिटरिंग करते हैं. इफ इट इज प्री डायबिटिक है तो 126 से ज्यादा होने का, और अगर 200 से ज्यादा है तो.
Good try. That was for diabetes type 2. I'm asking about GDM, gestational diabetes and pre-gestational diabetes. जी खड़े होकर बता दे, अपना नाम बता दे.
My name is Dr. Pathophysiology. सर गेस्टेशनल सबसे पहले हमें ये रूल आउट करना है अगर फर्स्ट ट्राइमेस्टर में पेशेंट आया है कि वो जो है ओवर डायबिटीज है या फिर जो गेस्टेशनल डायबिटीज है.
गेस्टेशनल का सिर्फ क्राइटेरिया बता दे.
गेस्टेशनल डायबिटीज में हम जब OGTT करते हैं तो अगर फास्टिंग में हमारे पास जो है 92 से ऊपर आता है, और फर्स्ट हार में हमारे पास 180 से अबव आता है, और सेकंड हार में 153 से अबव आता है, तो हम इसको जो है GDM.
एक रीडिंग चाहिए, 2 चाहिए, क्या चाहिए?
सर एक फास्टिंग और 2 आफ्टर जो.
नहीं, पॉजिटिव होने के लिए कोई एक पॉजिटिव हो या 2 पॉजिटिव?
सर इनमें से जो है 2 पॉजिटिव होने चाहिए या.
That was the twister. चले, सवाल ठीक माना जाता है, एक पॉजिटिव भी हो जाए तो वो जेस्टेशनल डायबिटीज है. वो प्री जेस्टेशनल तब कहेंगे जब फर्स्ट ट्राइमेस्टर या उससे पहले हुआ हो. थैंक यू सो मच. नाउ आई वुड लाइक टू रिक्वेस्ट So now I would like to request the audience to ask from the panelists, and accordingly the panelists will answer all the questions of the audience. So audience में किसी को कोई सवाल करना हो तो वो panelist का नाम लेकर उनसे सवाल कर ले, ताकि और panelist ने खुद कुछ बताना हो about these 2 sessions, they can contribute to it. Thank you. किसी को कोई question? माइक दे दें इनको. माइक.
सर मेरा क्वेश्चन ये है कि गेस्टेशनल डायबिटीज मेलिटस हो तो थ्रेडमिल पे जो है एक्सरसाइज करना चाहिए, अवॉइड करना चाहिए, या इट्स वाज contraindicated?
I think the question is from Professor Aisha Siddiqa or any other worthy panelist who can answer कि treadmill पे exercise करना चाहिए या वैसे walk करना चाहिए. आप अपनी राय please दे दें. Gestational diabetic patient exercise कैसे करे, कितना करे, treadmill पे करे, specifically पूछना चाह रहे हैं.
मैडम से पूछो.
Panelist इसमें क्या कहना चाह रहे हैं? मैडम भी जवाब दे देंगे.
Dr. Janan, it will depend on the available facilities. Obviously you need to do exercise if you are diabetic. Rather, even if you are not a diabetic, you need to have a physical exercise, and if you are diabetic, it is a must for you. So it depends, you know, when you are, if you have the facilities of treadmill, if you cannot go out, so it will depend on the available facilities of that individual, whether he is affording, what is the circumstances where he is living. So the exercise is needed from our side. How he is going to do it, it will depend on the facilities available to that patient. So individualized.
So my comment about this Dr. Janan, ये है कि while she is pregnant, the thing is that you have to first see the risks over there. For example, in diabetes, gestational diabetes, there are history of multiple miscarriages. Most of the time, bad obstetrical history is there. If the woman has threatened abortion or placenta is low-lying, then I think we will not advise her for exercise. Simply, she can walk. Most of the time, we ask them to restrict their mobility. So most of the time, the thing is that. But if there is no such history, there is no history of bleeding during the first trimester or in second trimester, after excluding the low-lying placenta or a Brepsho placenta, because most of the time, women with diabetes might be having hypertension as well. And when there is hypertension, risk of preeclampsia and a Brepsho placenta is there. She should avoid. But if you exclude all these things, I think she can do exercise on treadmill. That is what I understand.
Okay, thank you so much. Any other question from our worthy panelists? Yes, Dr. Rahim. Mike, please.
Excuse me, ये गाड़ी है AAQ698 अगर किसी की है क्योंकि इसने रास्ता बंद किया हुआ है AAQ698
AAQ698 किसी की गाड़ी है तो वो प्लीज जरा रास्ता
Thank you.
Thank you. जी डॉक्टर साहब.
Assalamualaikum. My name is Dr. Imla. I'm working as a acting assistant professor in pharmacology department, PMC. My question is from my respected teacher, Professor Aisha Siddiqa. Madam, what is the role of low-dose aspirin in preeclampsia? क्या एस्पिरिन मैडम जो हम देते हैं क्योंकि ये प्लेटलेट एग्रीगेशन को वो करता है क्या उसमें ब्लीडिंग की चांसेस नहीं है कि हम एक डिजीज को प्रिवेंट करते हैं दूसरे को वो करता है तो लो डोज एस्पिरिन के बारे में प्रीएक्लेम्पशिया थैंक यू
जी your question is that what is the role of low dose aspirin in pregnancy?
Yes, and
एक बहुत फेमस स्टडी हुई थी क्लास स्टडी उसमें ये है कि जैसे एंटीफॉस्फोलिपिड एंटीबॉडीज सिंड्रोम है bad obstetrical history, multiple recurrent first trimester abortions. तो एक स्टडी की गई कि it was seen that in the placenta, microthrombi were detected. And the further randomized controlled trial was done. 75 milligram of low-dose aspirin was given to one group and another group was given the placebo. And it was seen that the group which received the low-dose aspirin, 75 milligram once a day, the chances of first trimester abortion was low in that group. तो अब ये देखा गया है कि where the women has multiple first trimester miscarriages, here microthrombi has been detected in placenta and very successfully we have treated the patients with 75 milligram dose once a day, and where we have the positive anti-cardiolipin antibodies and where there is evidence of antiphospholipid antibody syndrome, apart from giving only aspirin, we are giving Clexane as a prophylactic dose. And Clexane is the low molecular as this heparin. It is given in the prophylactic dose, 20 milligram per day, but it should be given when the cardiac activity is detected on ultrasound. It should not be given before 7 weeks. Once you see that the cardiac flicker is there, start with prophylactic Clexane. We give it subcutaneously. We give it daily till the end of third trimester. It should be stopped because once the woman goes in labor, the chances of bleeding is there. I hope I answered your question.
Thank you so much. I would like to call our worthy panelist, Professor Jalaluddin, who is the head of cardiology, on stage, to please come on stage and have some remarks about today's presentation. My request to the panelists would be to Professor Khalid Shah, Professor Baki Durrani, and Professor Jalaluddin to contribute to our this session, to please address and kindly tell about the two presentations and any extra thing that you want to tell any one of you.
Dr. Mateen, thank you very much. Thank you very much for inviting me in the first session, as I was already committed at 4. I think it was an excellent session. I would congratulate first all the endocrine people from Quetta and the guests coming from Karachi and Lahore and KPK to integrate this society here in this part of the world. Excellent session and very good session from Dr. Naeem and from Madam Aisha. I think all agreed on these issues. Ramzan is coming, that's a serious area. We prescribe medications to our patients who are having cardiac disease, who are having diabetes. I think one area that we are very much missing is, instead of just prescribing pills, molecules, counseling is an area that we are very much missing, being physicians, being diabetologists. I think Professor Aisha is sitting over here, being gynecologist. What I believe is our job is not only just to write the pills, the molecules, just to control sugar. Apart from that, lifestyle intervention is very important. Right counseling of your patients during Ramzan. We see a lot of patients in hyperglycemic and hypoglycemic complications, those patients who are taking aspirin, who are taking statins, who are taking other molecules. Their right counseling is of paramount importance. And I think from this stage, we are having a lot of GPs, we are having physicians, we are having people who are working in far-flung areas. I think the message should be taken that when you are treating diabetes, you should treat diabetes as a syndrome, not just only controlling diabetes. I, being cardiologist, believe that we, on day-to-day basis, we do interventions, coronary interventions, peripheral interventions. But my belief is, in a country like ours, where there are limitations of resources of intervention, bypass surgeries, NIV equipments, I believe that you have to entertain diabetes as a vascular disease. So every diabetic patient, when I remember the NICE guidelines initially when they came, aspirin used to be given to every diabetic 45 plus. Now, you know, time is changing now. The current the trials, Exceed trials, they have shown that aspirin is no more indicated. But what is indicated, cholesterol became part of discussion. It became part of arguments. I think most of the diabetologists would also be on a line that statin should be part of your diabetic medication, whoever is having a high Framingham score, who is 45 plus. Why? Because it is endothelium of the vessel from where the disease starts, whether stroke, whether cardiac events, whether coronary events, whether peripheral complications of diabetes happen. So you have to respect, you have to treat the endothelium to avoid impending complications in future. And for that purpose, we have to, I'm again saying, we have to make the right counseling of our patients. And we have to, in busy clinics, I think my seniors, Professor Khalid Shah, Professor Baki Durrani, all are sitting, we see 10, 15 patients in 1 hour. Humanly, if you are honestly treating your patient, it is not possible to treat diabetic patients who is having hypertension, who is having ischemic heart disease in less than 10 to 15 minutes. But again, limitations of resources in 3 to 4 minutes. If you are, because I've been seeing busy clinics over here in Karachi, in Lahore, and even in abroad, we have to give good time to our patients about counseling stations. So with this, I thank you very much, Dr. Mateen.
Thank you so much, sir. Professor Khalid Shah will now speak.
I am thankful to the endocrine team of Ola Medical College. I'm also, there was a nice talk from Naeem Durrani and Aisha Sheikh. My one simple query is regarding from all the endocrine. Is apart from metformin, is there any other drug available? Because metformin does crosses the placenta. All insulin does crosses placenta. There is a drug like glyburide. Is that available? There was no mention of that in that presentations.
Dr. Aisha Sheikh, mic. There is glibenclamide, but madam will tell in detail.
Glyburide.
ग्लैब्यूराइड जिसको ग्लैबेनक्लामाइड यूके में और ग्लैब्यूराइड अमेरिका में कहते हैं, दैट इज अवेलेबल, बट देयर आर चांसेस ऑफ हाइपोग्लाइसीमिया एंड उसके भी जो है वो साइड इफेक्ट्स जरूर है, इट क्रॉसेस द प्लेसेंटा, बट मैडम विल टेल इन डिटेल.
Thank you, sir, for a very important question. So glyburide is actually glibenclamide. In US, glibenclamide is named as glyburide. And you are right that on glibenclamide, the data is still older than the use of safety of metformin during pregnancy. However, the meta-analysis suggests that there are higher chances of neonatal hypoglycemia and perinatal complications are higher in women who are treated with glibenclamide. No doubt, it would be a very important medication in situations where we do not have anything else to offer. So suppose a woman is cannot afford insulin at all, or she's living in a place where maybe insulin treatments cannot be managed properly. In situations where a woman might be very much reluctant to use insulin, over there, following metformin, one can give glibenclamide. Metformin does cross placenta in minor concentrations, but the fetal, the offspring data still has not suggested any significant risk to the offspring. Regarding insulins, the insulins which are generally used do not cross placenta, but only Lispro insulin, if it goes beyond 50 units per day, it does cross placenta. So other insulins like NPH, large Detemer, and regular and Aspart does not cross placenta at any concentrations.
Thank you so much. Professor Baki Durrani, can you please?
सबसे पहले तो शुक्रिया इन तमाम नौजवानों का जिन्होंने आज के इस नशिस्त को अहमियत बख्शी, वेट दिया, particularly you all the juniors. फिर मैं शुक्रगुजार हूँ इन दो स्पीकर्स का, आयशा शेख साहिबा का, नईम साहब का, और ख़ासकर इस वक्त हमारे दरमियान इरशाद खोसू साहब बैठे हैं, उनका बहुत बहुत शुक्रिया। जब यहाँ पे एंडोक्राइनोलॉजी या डायबिटोलॉजी का कोई तस्वुर नहीं था, तो उसने ये रास्ता इख्तियार किया, और उस वक्त से अब तक बहुत सारे लोग आ गए हैं। हम उनको इस सिलसिले में मीर कारवां समझते हैं। इस चैप्टर का जिसकी आज हमने इनॉग्रेशन की है। प्रोफेसर ज़फ़रुल्लाह साहब हमारे दरमियान हैं, इस वक्त हमारे डिपार्टमेंट है। बाकी बहुत सारे लोग जो हमारे इस काफिले के मेंबर्स हैं, वो आज सारे खुश हैं, हमारे दरमियान बैठे हैं। एक सवाल इन जूनियर्स के दरमियान बहुत सारे लोगों के जहनों में होगा कि जी डायबिटीज़, थायराइड, फ्यूक्रोमोसाइटोमा, कुशिंग, ये तो हम सालों साल से, सदियों से रादर ट्रीट करते आ रहे हैं। ये जो थोड़ी सी चेंज नज़र आ रही है इस एरा में, ये क्या है? अभी जो प्रोफेसर जलाल साहब ने एक बात की कि आप वक्त दे पेशेंट को, उन्हें सुने, ये जज करे कि उस पेशेंट का उस वक्त का मसला क्या है। एक जर्नल फिजिशियन में और एक स्पेशलिस्ट में, या आज के एतबार से एंडोक्राइनोलॉजिस्ट में फ़र्क ये है कि वो उससे ज़्यादा कुछ करे जो एक जर्नल फिजिशियन करता है, या एक कंसल्टेंट मेडिसिन का जो जनरल मेडिसिन का है, प्रोफेसर है, एसोसिएट है, असिस्टेंट है, उससे वाकई में डिफरेंट नज़र आए। और अगर हम सब एक किश्ती के सवार हों तो फिर शायद वो ऑब्जेक्टिव हासिल नहीं होगा जिस ऑब्जेक्टिव को हासिल करने के लिए आज हम यहाँ बैठे हैं। एक चैप्टर का हमने इसकी इब्तिदा की है, बाकी पाकिस्तान में पहले से, आल्दो कि ये इनिशियल स्टेज पे हम आगे एक्सपेक्ट करेंगे आपकी सालाना नशिस्तों में, नॉट एट दिस पार्ट। ये आज की के 2 लेक्चर से जाहिर सी बात है हम उस नतीजे पर तो नहीं पहुंच सकते, लेकिन ये है कि आपको उससे ज्यादा कुछ करना होगा, उसकी डेप्थ में जाना होगा। आल्दो के आज के दोनों सब्जेक्ट इस एतबार से बड़े इंपॉर्टेंट थे। एक ये कि प्रेगनेंसी विद डायबिटीज, उसके मसाइल क्या हैं और उसका हल क्या होना चाहिए। एक मैसेज तो कम से कम मैडम ने दिया, क्या आप डायबिटिक प्रेग्नेंट वुमेन को बाकी डायबिटिक से अलग एक स्टेटस दे, उसको इम्पोर्टेंस दे। ये पैगाम मेन जो हमारी मासेस को मिला, बज़ात खुद ये बहुत कुछ है। दूसरी बात, डायबिटीज एंड रमज़ान, नईम साहब से मैंने आगे जाके ये बातें पूछनी होंगी। कुछ चीज़ें ऐसी हैं जिसमें हमारे माशरे के अंदर उसको पब्लिक में लाने से पहले एक डिबेट उसके ऊपर होनी चाहिए और उस पर आपको एक अथॉरिटी लेनी चाहिए। किसको रोज़ा रखना है, किसको नहीं रखना है, इसका हमारी सोसाइटी में एक और एस्पेक्ट भी है जो रिलीजियस एस्पेक्ट है। शायद जिसे हम कहें कि आप रोज़ा छोड़ दें, वो किसी मजहबी स्कॉलर के पॉइंट ऑफ व्यू से उससे कहे कि जी अब तो आपको कफारा जो है वो बहुत बड़ा अदा करना होगा। तो मैं ये अर्ज करूंगा कि इस मौजू को अव्वल तो छेड़ा न जाए, और अगर छेड़ा जाए, चूंकि हम तालीम याफ्ता लोग हैं, कब तक चीज़ों को हम पस पुश्त डालते रहेंगे? नहीं डालेंगे, ले आएंगे। रमज़ान शरीफ अभी बिल्कुल सामने है। तो एक जो तस्वुर आपको लिटरेचर में मिलता है वो बहुत मुख्तलिफ है उससे जो ज़मीन पे हकीकतें हैं। तो मेरी राय ये है कि ये मशवरा जो भी फिजिशियन एंडोक्राइनोलॉजिस्ट देगा तो बहुत सोच के दे। बाकी आपकी इस नशिस्त के लिए हम सब आपके ममनू हैं। उन लोगों का कि जिन्होंने इस नशिस्त को अरेंज करने में आपकी मदद की, हमारी मदद की, यानी गेट्स फार्मा का। थैंक यू वेरी मच फॉर टुडेज सेशन।
Thank you all, our worthy panelists. So now for our next two lectures, we had 5 panel of experts. So thank you all, Professor Jalaluddin, Professor Baki Durrani, Professor Khalisha, Professor Aisha Siddiqa, and Professor Janzeb Nasser. Thank you all. So for our next 2 lectures, our panel of experts, I will invite them all to please occupy their seat. Professor Dr. Zafarullah, Head of Department, Endocrinology Department, BMCH, Quetta. So please come and have your seat. Our second expert panelist is Dr. Irshad Koso. So ex-professor and ex-HOD Endocrinology, BMCH, Quetta. So our third panel of expert, Dr. Suresh Kumar. So he's a consultant physician, consultant endocrinologist, Civil Hospital, Quetta. So, Dr. Mujib Tareen, Professor and Head of Department Cardiology, Civil Hospital, Quetta, he is not among us. So, for this session, we had 2 lectures. So, I will invite our first presenter, Dr. Atif Munir. So, he is a renowned consultant diabetologist and endocrinologist, Assistant Professor Medicine, Fatma Jinnah Medical College, Lahore. Dr. Atif Munir.
कौन कौन से ओके अस्सलाम वालेकुम जी सो आई नो कि मैं और डॉक्टर साहब रह गए हैं 2 स्पीकर्स और आपके और खाने के दरमियान हम पहाड़ बने हुए हैं बट आई विल ट्राई टू मेक इट as less painless as possible. We have a very interactive session, so you will find me not standing here. I will be right there between you because you guys have to tell me what needs to be done for this patient. So I'm just going to give you some cases. My topic is diabetes and Ramadan, and I'm not going to show you any evidence slides, any guidelines. I'm going to give you some cases which will walk through your door day in, day out, before and during Ramadan. So be prepared and be ready. So my colleague already, Dr. Naeem, has already discussed this verse. I think because we live in an era of evidence, वो लोग जिनको आप convince करना चाह रहे हैं कि they should not fast medically, you need to have this reference ready. Just ये कह देना मरीज को कि वहाँ लिखा हुआ है, यहाँ लिखा हुआ है, अल्लाह ने कहा, is not enough. I think it's an era of evidence. So if you want to ask someone not to fast and avail the exemption Allah gives them, you need to have the reference with you. De ayat hai ye hai. One of them will go back home and check, and that will be your win. So I think we should encourage people who can fast safely, as per what we're going to discuss throughout this presentation, that they should fast. But people who think medically, as per our assessment, that fasting may be more harmful for their health, then we should kind of encourage them as well that this is not the end of the world. So with references and everything, with rational reasoning, just don't have a blanket policy कि आप रोजे नहीं रख सकते, आप रख सकते हैं. This will put them off both ways. Assess them, counsel them, जैसे सर ने अभी बताया. Have an open discussion and give them rational reasoning why you want them not to fast. Medical risks we've already discussed, so we'll skip it. These are some myths. ये वो myths हैं 2 जो चलती आई हैं, चलती रहेंगी और चलती ही रहनी है. Just like the myth के glucophage गुर्दे खराब कर देती है. So this is something that will live with us until all of us are practicing. So you want to reassure your patients with diabetes कि रोजा शुगर चेक करने से नहीं टूटता है, इंसुलिन लगाने से नहीं टूटता है, हम सबको पता है. You must have some references in your armory to give them to take home. They will feel reassured if you reference them. किसी कोई घर जाके reference check करे ना check करे, that's up to them. You do your bit and reassure them. Okay. You should be able to support most people with diabetes to fast safely. And this is what we're going to do. Pre-Ramadan assessment is an absolute must. What I feel really helpful in my everyday practice is, yes, there are a lot of guidelines. The guidelines we've given you, किसी को पता है उस guidelines के कितने pages हैं उस document के? Anyone? जो guidelines अभी डॉक्टर नईम ने mention की हैं या हम बता रहे हैं जी IDF की guidelines हैं, किसी को पता है उसके pages कितने हैं? 340 something. अगर हिम्मत है, हौसला है, पढ़ लें. It's a very good document. अगर मेरी तरह हिम्मत हौसला नहीं है तो this is what we're going to do. We're going to have discuss a very practical and pragmatic approach. Some of it is based on guidelines, some on experience. This is from the guidelines, but you will find it very difficult to tailor and put that patient into that guideline. And keep in mind, it is a 340-page document. So, but it's a worth reading document. So what I usually find very helpful, if people say, Dr. Saab, क्या मैं सकता हूँ कि नहीं सकता, I usually ask them before anything else, कि पिछले रमजान क्या किया? And you will be surprised to find out कि लोगों ने क्या नहीं किया रोजे रखने के लिए to be safe. They have adopted all sorts of treatment changes by their own accord, किसी से मशवरा किए बगैर. We are all, alhamdulillah, all Pakistani, हम सुनते सब की हैं, लेकिन करते वो हैं जो. So people would have done lots of अजीबो-गरीब things with their treatments previous Ramadan, but it worked for them. ठीक है? They have survived previous Ramadan safely with whatever they did. So I usually ask them, पिछले रमजान क्या किया? and usually they come up with मैंने अपनी insulin dose को ये किया, मैंने दवाई की dose को ये किया, and that's very helpful information. I may not copy and paste that same information to help them fast safely this Ramadan, but I will tailor the treatment and my advice around what they did last Ramadan. So it's really important to know what they did last time. Apart from that, obviously you need to know कौन सी दवाई ले रहा है, कितनी dose में ले रहा है, how frequently they are monitoring, HbA1c कितना है, do they have any comorbidity, really important, especially kidney disease. We know we live in a hot, humid climate, long fast, गर्मियों के रोजे. Anyone with kidney disease is asking for trouble if he or she is fasting, just because of the risk of dehydration. So we need to know all this, and we're going to do all this with all the cases. In fact, you're going to do all this for me. You need to individualize your decision making to the person who's sitting in front of you. आप जितनी मर्जी guidelines पढ़ लें, आपको जब तक individualization करनी नहीं आएगी, आप किसी patient को उस guideline में fit नहीं कर सकेंगे. So what I'm going to describe is based on evidence from the guidelines and experience. So if you combine evidence with experience, you can do the best, not only for yourself, but for your patients. So trainees, be ready. I'm coming your way. This is our first patient. Have a read. Type 2 diabetes, is 45-year-old male. No other comorbidity. Okay? You're going to answer. You're going to answer. So that's why I'm here. Metformin twice daily, glamiprid 4 milligram once daily, Ramipil once daily. What else you want to know? What else you want to know? Shout out. There is no right or wrong answer here. Shabash. There is no hypoglycemia. और क्या चाहिए? और क्या चाहिए? Good. Shabash. So this is his HbA1c. He does his reading twice a week. Fasting is around 120. You really want to know renal function tests. हो सकता है इन लोगों ने कभी जिंदगी में कभी renal function test ना कराया हो. It's a must to get it done before Ramadan. Lamba roza, garmi ka roza, dehydration, etc., etc. So, can he fast? Yes. Would you like to make any changes in the treatment to make him or help him fast safely? क्या करना चाहेंगे? Any changes to a treatment? Anyone? What would you recommend? This person is sitting in front of you in your clinic. Ramzan is 2 days away. You've got the results. He wants to fast. You're okay to tell him to fast. Bas. So he's at risk of hypoglycemia. He's running reasonably good control. By Pakistani standards, 7.5 HbA1c अगर किसी मरीज का मिल जाए तो मुझे तो 2 दिन खुशी से नींद नहीं आती. क्योंकि we're used to seeing 8s, 9s, 10s, 12s. 7.5 pretty okay. लंबा रोजा, गर्मी का रोजा. Yes, exactly. Thank you. Just reduce his glamiprid to half. He should be okay. Good. You're getting the gist of it. Next case. Type 2, 6 years. Hypertension, 2 years. No other comorbidity. Metformin, 1 gram twice daily. Gliclazide, 80 milligram twice daily. Losartan. What do you want to know? What do you want to know? Just like the last person. Absolutely. Yeleji. There you go. Is he okay to fast? Good, Shabash. Any changes to his treatment or her treatment, sorry? Metformin, no issues, renal function are normal, no risk in fasting, nothing. What about gliclazide? With HbA1c of 6.5, he's an exceptional patient. Yes, I would just stop the gliclazide. He should be okay. Remember, diabetes or Ramzan ek dusre ke liye nahi bane hain. It is not possible to have perfect blood sugars and fast for 30 days. All we are trying to do with these treatment changes is to help him fast safely without any hyper or hypoglycemia or dehydration related problems. To help him, support him fast, just stop his gliclazide. He will be fine or she will be fine. Okay, next. What else you want to know about this lady? और ग्लूकोज स्टेरोलिसिस हो चुका है इसलिए तो जेस्टेशनल डायबिटीज लेबल किया हुआ है. फास्ट और नॉट फास्ट. कितने लोग कहते हैं शी इज ओके टू फास्ट? हाथ खड़ा करें. ओके, जस्ट 1 2 3. डॉक्टर आयशा को माइक दे दें. डॉक्टर आयशा, आपकी पेशेंट है, आपके साथ क्लिनिक में. आपने IDR, IDF की जो 340 पेजेस की गाइडलाइंस है वो आपने रट्टी हुई है, बताएं जी, फिट करें इसको।
Hear me.
हाँ जी, हाँ जी।
So during pregnancy and breastfeeding, even Allah gives exemption, even if you do not have diabetes. And if you are 30 weeks, although your growth scan is right now normal, but when you fast, then there will be period of almost 14 to 16 hours of fasting, followed by an iftar time, or during seher, there's a chance that there would be glycemic peaks after those 2 meals. And those peaks have a direct association with fetal macrosomia, which we need to avoid. So during pregnancy, you are actually a very high risk category for fasting, and medical advice is actually against fasting.
Okay. So the guidelines, the DAR guidelines we've all been talking about, the evidence of pregnant women fasting, there is not a wealth of evidence. Whatever little evidence is available, उसमें कोई बहुत ज़्यादा harms और risk भी सामने नहीं आए, but कोई बहुत ज़्यादा benefits भी सामने नहीं आए. She's right. If she's my patient and the evidence is wishy-washy and the religion is giving you the exemption, and you don't want to be the person कि अगर कोई excursions की वजह से कोई fetal problem आ गया, you want to be the last person to be held responsible. So ask her to avail the exemption. Wishy-washy evidence, open discussion करें. Evidence इतना ज़्यादा नहीं है. You have religious exemption. Use that exemption we used. Use that ayat we used. Use the reference we used. And rational reasoning के evidence कोई बहुत ज़्यादा नहीं है. It can go either way. We don't know much. When we don't know much, we don't do it. Full stop. आगे चलें. There's no right or wrong answer here. The guidelines do mention people, well, females who have gestational diabetes, who are either diet controlled or even metformin controlled, can fast. You can support them fast. But why take the risk? Why take that unwanted, unnecessary risk? Okay, ye लीजिए. Here comes SGLT2 inhibitors. A lot of our patients are now on SGLT2 inhibitors. A lot of them will be on SGLT2 inhibitors in the times to come. So what else you want to know? Trainees. Same things. हाँ जी, क्या करना है? Remember, in all scenarios, these are all scenarios from my clinic. इसमें कोई गलत और कोई सही आंसर नहीं है और हो भी नहीं सकता. This is where individualization and rational reasoning comes in. So, आपका patient, mic लाएं जी, mic लाएं. Mic. So,
HbA1c is 8.5 and the duration of diabetes is 15 years. Still, I would say that this patient comes in the yellow category, and this patient may or may not fast. Either way we can go.
Absolutely. If he wants to fast, I can support him to fast safely. I wouldn't change any of his medicines. Remember, please, Ramzan se pehle, at your pre-Ramadan assessment is not the best time to change treatment, and change treatment that's the worst time to change treatment. भाई हो सकता है आपको ट्रीटमेंट चेंज करें, 2 दिन बाद रोजा शुरू हो रहा है, उसको परसों से डायरिया शुरू हो गया, तो ना सिर्फ वो आपके पास वापस भी नहीं आएगा बल्कि इतनी बड़ी गालियां भी देगा. ठीक है. It's not the time to change. If he wants to fast, yes, I will give him all the advice for dietary, frequent monitoring, adequate hydration before sehri, after iftari, but he's okay. Dapagliflozin, vegan SGLT2 inhibitors, जो main risk, theoretical risk सबके जो है वो ज़हनों में गूंज रहा है वो ये है कि dehydration. There are studies, small studies available because they've been out in the market for a few years. There are studies where SGLT2 inhibitors, especially dapagliflozin, has been continued in Ramadan. And there has been no significant risk of dehydration. It has not materialized. It is okay. It is safe to continue. No issues if he wants to fast. Fine. इस पेशेंट को अगर आप पाकिस्तानी पेशेंट्स को डार गाइडलाइंस में फिट करने की कोशिश करेंगे तो हार्डली कोई 5% मरीज थ्योरेटिकली रह जाएंगे जिनको आप रोजे रखने की इजाजत देंगे. 95% को आपको ना कहनी पड़ेगी. रखनी उन 95% ने फिर भी है. Why not help and support them and build that rapport with rational reasoning? Help them fast safely. They will come back to you. They will develop that bonding. The guidelines में उनको fit किया तो, as I said, 5% पाकिस्तानियों को भी आप रोजे नहीं रखवा सकेंगे. आपको 95% को ना कह के बुरा बनना पड़ेगा. Rational reasoning का time हमारे पास वैसे नहीं होता. तो बस आपकी तो practice पे चल पड़ेगी. 5. इतनी खामोशी, इस्कीमिक हार्ट डिजीज ही डाली है, कोई प्रेगनेंसी तो नहीं डाल दी दोबारा। ये लें जी। Okay, he's right. Again, no right, no wrong answer. पेशेंट पे भी तो डिपेंड करता है ना, पेशेंट ने कहना है, कई पेशेंट ऐसे आएंगे, जरूरी नहीं हम उनकी बात माने, ऑब्वियसली वो आएंगे जी रोजा तो मैंने रखना ही रखना है, कम वट में। आपकी एडवाइस पे नहीं रखेंगे कि दवाइयों के करने दो, पुफी या ताई की एडवाइस पे रख लेंगे। वो मैं मामे ने दसिया सी तू अपनी है गोली अद्धी कर ले, मैं रख लेता, तो तुसी नहीं मैंने रखवा सकते, आप बुरे बन जाएंगे। मैं ये नहीं कह रहा कि आप बुरे बने, आप यू नीड टू स्टिक टू योर गन्स, प्रोफेशनल गन्स एडवाइस। माय ओनली कंसर्न इसके इसको साथ इस्कीमिक हार्ट डिजीज भी है, जाहिर है 1 महीने के और हाइपरग्लाइसीमिया से उसको कुछ नहीं होगा। रादर देन मैं इससे ये डिस्कशन करूं, वो जो 10 मिनट के लिए मेरे पास आ ही गया बोल भटक के, आई वुड ट्राई टू कन्विंस हिम कि यार रोजे पे भी बात कर लेते हैं, पहले ये अपने एचबीएनसी का क्या करना है जो तुम्हें स्टेंट भी डला हुआ है, और you're already a very high person because you've already had a event, you got a stent in, इसको बचाने का तुम्हारा क्या प्लान है? रोजा भी रखवा लेंगे, वो चले वो भी ठीक है। Despite, so I would try to sway him away from fasting. 9% risk of hyperglycemia, symptomatic hyperglycemia, long term complication कोई नहीं हो सकती 1 महीने के hyperglycemia से, क्या होना है? वो तो पीछे से चल रहे, 1 महीने में कुछ नहीं होना, ये तो हमें पता है मैक्रोवैस्कुलर माइक्रोवैस्कुलर years, बट 1 महीने में सिर्फ ये हो सकता है उसको सिम्टोमेटिक जरूर हो जाए अगर अभी नहीं है रमजान में। And remember one thing, if someone you're allowing to fast with some changes to insulin or दवाइयां or whatever, इसका मतलब ये नहीं जो चेंज आपने रमजान से पहले या रमजान पहले रोजे में कर दिया वही 30वें रोजे तक काम भी करती रहेगी। वो इतने लंबे रोजे हैं, ग्लाइकोजन रिजर्व्स थोड़े से कम होने शुरू हो जाएंगे, मॉनिटरिंग का आपने बता दिया, यू माइट हैव टू चेंज योर एडवाइस एंड टेलर द ट्रीटमेंट अगेन काइंड ऑफ मिड रमजान। सो ये नहीं है कि एक एडवाइस दे दी तो यू कैन कॉल हिम। दिस पर्सन आई वुड बी अ बिट रिलक्टेंट टू अलाउ हिम टू फास्ट, कार्डियोवैस्कुलर हुआ हुआ है, पहली एचबीएनसी 9% चल रहा है, मुझे सिर्फ ये है कि सिम्टोमेटिक हाइपरग्लाइसीमिया मुश्किल हो जाएंगे उसी के लिए रोजे। आई विल ट्राई टू कन्विंस हिम, बट इफ नॉट यू आर राइट, यू कैन टेलर इट अराउंड, कुछ नया मत शुरू कीजिएगा बस। दिस इज नॉट द टाइम टू स्टार्ट इंसुलिन। हाँ, अगर वो रोजे नहीं रखने पे कायल हो गया देन यस। एब्सोल्युटली, ये तब होगा अगर वो शबान में आपके पास आ गया तो माशाल्लाह। हम हैं पाकिस्तानी, हमें रमजान की याद और ट्रीटमेंट चेंजेस की याद कब आती है? जिस दिन अगले दिन पहला रोजा होता है। प्री प्लानिंग डज नॉट एग्जिस्ट इन आवर डिक्शनरीज, प्री प्लानिंग हमारी डिक्शनरीज में नहीं है, वी नीड टू बी ऑनेस्ट ना। तो ये अगर आप लकी होंगे, अगर आपके पास ये शबान शुरू होती आ गया, यस यू कैन यूज दैट अपॉर्चुनिटी, बट ये आएगा आपके पास रमजान से पिछली रात या फोन आएगा कल से रोजा डॉक्टर साहब बताएं मैंने अपनी दवाइयों को क्या करना है। वो ये भी नहीं पूछेगा कि रोजा रखूं या ना रखूं, उसका सवाल ठक होगा, मुझे बताएं मैं अपनी दवाइयों को क्या करूं, रोजे तो मैंने कल से रखने। टेलर करना पड़ेगा। ओके, 10 more minutes, आई विल बी फिनिश्ड। हाँ जी, किडनी डिजीज है, पौधे को 2-3 दिन पूरा पानी ना मिले तो क्या होता है? हाँ, ये किडनी पौधा है, 2-3 दिन पानी पूरा ना मिला लंबे रोजे में तो इसने मुरझा जाना है, मुरझाया हुआ पौधा वापस नहीं आ सकता, फिर डायलिसिस ही होगा। डिहाइड्रेशन, रैशनल रीजनिंग करें, इट्स अ क्लियर नो फॉर हिम। HbA1c 6 हो, 5 हो, 8 हो, 10 हो, 15 हो, मुझे उसके HbA1c की कोई इतनी परवाह नहीं है, मुझे उसकी किडनीज की है, वो चलेगी तो वो वापस नहीं आ सकती। वो भी है, असल तो डिहाइड्रेशन किडनी। वो एक पेशेंट आया, बिल्कुल यही सिनारियो था, यही पेशेंट था बल्कि शायद, इफ आई एम नॉट रॉन्ग, कि जी रोजे रखने हैं, तो बल्कि मैंने खुद पूछा रोजे रखने, हाँ जी रोजे तो रखने, अगला रमजान हो ना हो। मैंने कहा यार रख लो, ना रखे तो शायद अगला रमजान नसीब हो जाए, रख के शायद मुश्किल है, फिर भी रखे, और वही हुआ जिसका डर था। He ended up on dialysis after Ramzan. Be clear, be very clear. जिसको नो कहनी है उसको ठोक बजा के नो कहें, उसने नो लेनी है नहीं लेनी, but you need to fulfill your professional and moral responsibility. You don't have to make everyone fast. Okay जी। हाँ जी, कोई ट्रेनीज बताएं, यही आने आपके पास पेशेंट्स। उस वक्त गाइडलाइन 340 पेज खोलने का टाइम नहीं होगा कि इसको कहाँ फिट करना है, उस वक्त तो ऑन द स्पॉट डिसीजन मेकिंग होगी। हाँ जी, कैसे? नहीं नहीं ठीक है, ही कैन फास्ट, ओके, बट क्या करेंगे? रिमेंबर, ट्रीटमेंट नहीं चेंज करना। रमजान से एक दिन पहले आया तो क्या चेंज करना है? यानी ट्रीटमेंट यानी चेंज नहीं करना, हाँ मॉडिफिकेशन यस। सो एक ऑप्शन ये है उसकी वो सहरी वाली डोज आधी कर दें या बंद कर दें, बड़ा अच्छा कंट्रोल है, ओवरऑल रीजनेबल कंट्रोल है। आधा आधा कर दें या बंद कर दें सहरी वाली डोज, एंड आस्क हिम टू कीप मॉनिटरिंग फ्रीक्वेंटली, या यू कैन सपोर्ट हिम टू फास्ट सेफली। हाँ जी, जी क्या करना है? Is anything ideal in this world? Is anything ideal in this country? Is anything ideal in your province? Nothing is ideal in this world. Yes, you are right. Ideally तो इतना हाइपरग्लाइसीमिया सिम्टोमेटिक हो जाएगा, 5-6 रोजे रख सकेगा, उसके बाद सिम्टम्स काफी आएंगे इसको हाइपरग्लाइसीमिया के, 5-6-7 रोजे निकाल जाएगा, बट उसके बाद इट्स अ यस नो, यू कैन यू कांट। अगर उसको रखवाना ही है तो बस उसे यही मैं कह सकता हूँ कि कुछ भी चेंज ना करो, चेंज नहीं करना। हाँ, फ्रीक्वेंट मॉनिटरिंग करे, हाइड्रेशन का ख्याल रखे, और जिस पॉइंट पे उसको लगे कि उसकी बॉडी उसका अब साथ नहीं दे रही, वहां से छोड़ दे। हाँ, वहां से छोड़ दे। पिछले सारे सिनेरियोज दैट आई हैव प्रेजेंटेड टू यू, उसमें इट गोज विदाउट सेइंग, पूछना सबसे goes without saying, all the scenarios that I presented until now, none of them had recurrent or problematic hypoglycemia. We should ask everyone. Yeah. Very high risk. पहली hypoglycemia इतना ज्यादा हो रहा है, रमजान और रोजे, it's an absolute no. It's an absolute no. I don't have to read any guidelines for this. It's an absolute no for him, her, him. So yeah, recurrent hypoglycemia already हो रहा है, रमजान में कैसे संभालेंगे? GLP-1 आपके यूज होता है? GLP-1 गुड। सो देयर इज अ सिनेरियो, GLP-1 liraglutide इंजेक्टेबल है, रिमेंबर इंजेक्शन लगाने से इंसुलिन हो या liraglutide हो, सबक्यूटेनियस इंजेक्शन से रोजा नहीं टूटता है। यस एब्सोल्युटली नो चेंज। इनमें से कोई भी चीज हाइपोग्लाइसीमिया नहीं कर सकती। नो चेंज, कंटिन्यू सेम ट्रीटमेंट, कैरी ऑन। लास्ट टाइप 1 आ गई फॉर अ चेंज। टाइप 1 ये ले, देखिए टाइप 1, सो लाउड एंड क्लियर मैसेज, टाइप 1 इज अ डिफरेंट बॉल गेम। प्लीज टाइप 1 को टाइप 2 की तरह यस नो नहीं शुरू में कर देना। टाइप 1 में, so most of the physicians or trainees out there, if there is someone with diabetes who has come to you with regards to advice regarding fasting with diabetes in Ramzan, if there is one person or one category that you should refer to endocrine colleagues, that's your type 1, please. हमने सिर्फ इसका कंट्रोल, इसका हाइपो, इसका वो नहीं देखना, हमने इसकी और बहुत सारी चीजें देखनी है। हमने इसके डीके, इसका पूछना आखिरी कब हुआ था, हमने मॉनिटर भी करता है कि नहीं करता है। अगर कोई एक वैसी मॉनिटरिंग नहीं कर रहा, वो रमजान में रोजा रख के यूर जस्ट आस्किंग फॉर ट्रबल। बहुत सारी चीजें हैं जो हमने एज एंडोक्राइन इसकी और एवेल्युएट करनी है, अपार्ट फ्रॉम व्हाट वी ऑलरेडी इवैल्यूएटेड फॉर ऑल द केसेस दैट वी गॉन थ्रू। सो टेक होम मैसेज, इफ अ टाइप 1 कम्स टू यू, फास्ट नॉट फास्ट की डिस्कशन के लिए प्लीज, दैट्स वन पर्सन आई वांट यू टू रेफर। इफ you can hold your other 10 with you, no problem. If there is one category of patients with diabetes, you should refer to your endocrine colleagues for this or for anything else. I would say that's your type 1 diabetes patient. Okay? So these are the guidelines. If you have the guts and the courage, go through them. It's an excellent document, very comprehensive, but very lengthy, but really amazing document. And thank you very much.
Thank you so much, Dr. Atif Munir, for excellent case presentations. So our next speaker for today's seminar will be Dr. Hussein Afridi. So he is Assistant Professor of Medicine, Consultant Physician, Diabetologist, and Endocrinologist. So IBP OPD Hayatabad Medical Complex, Peshawar. Dr. Hussein Afridi.
अस्सलाम वालेकुम। हम प्रेजेंटेशन तो हम स्टार्ट करेंगे, विल गो थ्रू इट। क्या आप हाथ खड़ा कर सकते हैं जिनके घर में डायबिटिक्स हैं? प्लीज हाथ खड़ा कर दें जो या डायबिटिक्स है या उनके घर में डायबिटिक्स। तो क्वाइट अ लॉट, ठीक है ना। आतिफ की प्रेजेंटेशन की तरह जिस तरह आप लोगों ने सुनी है उसी तरह जो है ना ये प्रेजेंटेशन भी सुननी है, ठीक है ना। आतिफ, थैंक यू वेरी मच। शोर बहुत कम हो गया था, या तो कुर्सियां कम हो रही हैं, मेरे ख्याल में लोग कम हो रहे हैं, बट योर प्रेजेंटेशन वाज सो इफेक्टिव कि लोग बोल ही नहीं रहे हैं। डॉक्टर नईम की प्रेजेंटेशन, डॉक्टर आतिफ की प्रेजेंटेशन ने मेरे लिए बहुत सिंपल कर दिए एवरीथिंग। और हम जल्दी जल्दी जाएंगे, स्लाइड्स तो बहुत ज़्यादा हैं, लेकिन कोशिश करेंगे हम उसमें टाइम बहुत कम स्पेंड करें। रिपीटिशन बहुत ज़्यादा है, लेकिन एज वर्दी पैनलिस्ट रिपीटिशन मेमोरी का एक हिस्सा है और हम कोशिश करें कि उसको शायद कि तेरे दिल में उतर जाए मेरी बात, ठीक। विद द परमिशन ऑफ द पैनलिस्ट एंड अगेन वेरी थैंकफुल टू आवर कोलीग इन Balochistan, Quetta, regarding the PES chapter. My hospital a rainy view है और आजकल हम जो है ना रेनी सीजन में, बट इट जस्ट फिनिश्ड। हैदराबाद मेडिकल कॉम्प्लेक्स हमारे एक बेहतरीन काविश हैं फ्रॉम आवर सीनियर प्रोफेसर डॉक्टर A.H. आमिर। हमने तकरीबन अभी तक जो है ना 8 से 12 जो है ना एंडोक्राइनोलॉजिस्ट, FCPS एंडोक्राइनोलॉजिस्ट पैदा किए हैं और उनमें प्लीज
RY 320 प्रोबॉक्स से वो गाड़ी से का रास्ता बंद है बाकी साहब का, तो वो किसी काम से घर पे आ रहे हैं, इसीलिए सॉरी फॉर इंटरप्शन।
इट्स ओके।
320 प्रोबॉक्स।
तो अभी जो हमारे प्रेसिडेंट इलेक्ट हैं इब्रार साहब, वो भी हमारी ट्रेनी है वार्ड का, और हमारे और भी अल्हम्दुलिल्लाह इस तरह जेम्स अभी आ रहे हैं और एंडोक्राइनोलॉजी डिपार्टमेंट डेवलप हो रहा है। तो लेट्स स्टार्ट विद द टॉकिंग। I will be just talking about the management of diabetes. Management of the diabetes in Ramadan as per guidelines. आतिफ ने कहा guidelines को जरूर रखें माइंड में, लेकिन personalization important है with your experience. Always go through your experience. अपने इलाके के मुताबिक देखें। रमजान यहाँ पर कितने घंटे चलेगा फास्टिंग का ड्यूरेशन सर? 15 घंटे, ऑलमोस्ट 15 घंटे। सो आप एक डायबिटिक पेशेंट को 15 घंटे जो है ना निहार रखेंगे, आप उसको कुछ पानी नहीं पिलाएंगे, तो कंडीशन देखते जाएं। लेट्स स्टार्ट। हाउ डज इट वर्क? ओके ओके अगेन बिस्मिल्लाहिर रहमानिर रहीम, विद द नेम ऑफ अल्लाह, the most gracious, the most merciful. Again यही आयत बार बार कोट हो रही है और ये डायरेक्टिव है, एक डायरेक्टिव है। डायरेक्टिव मतलब कि इसमें कोई दूसरी राय बनी नहीं सकती। यू डोंट नीड एनी एक्सप्लेनेशन फॉर इट। आप पर रोजे फर्ज कर दिए गए हैं, और कौन से महीने में? रमजान के महीने में, क्योंकि अल्लाह ने इसको इतना बड़ा जो है ना वो दिया हुआ है कि इसमें कुरान मजीद भी नाजिल हुआ है। तो लोग जो है ना अकीदत की वजह से जिस तरह भी जिस कंडीशन में हो वो रोजा रखना ही चाहते हैं। हम उनको बार बार मना करते हैं, लेकिन दे वुड से डॉक्टर साहब बल रमजान बवीना मौका ना, इफ यू अंडरस्टैंड दी पश्तो। वही बात आतिफ की के कहते हैं कि दूसरा रमजान मुझे देखने को मिलेगा कि भी नहीं, लेकिन दे वुड फास्ट बावजूद मना करने के। लेकिन कुछ चीजें ऐसी हैं कि आप अगर एज ए डायबिटोलॉजिस्ट, एज ए फिजिशियन, एज ए जो है ना सीनियर एक्सपीरियंस लोग तो आप उनमें से जो है ना 90% को आप जो है ना अपनी बात मनवा सकते हैं, वो तरीकाकार है और उसको वो आपके एक्सपीरियंस में है, लेकिन यू नीड टू लिसन। अच्छा, इसमें बट इफ एनीवन इज इल, ये चैप्टर जो है ना हमारे सीनियर यहाँ पर प्रोफेसर साहब थे, सॉरी आई डिडंट रिमेंबर हिज नेम, यही जो है ना एक एरिया है, यही एक एरिया है, बट इफ एनीवन इज इल, और ये आप लोगों ने डिसाइड करना है। यहाँ पर फिजिशियन है, यहाँ पर यू पीपल आर डिसाइडिंग कि आप उनको जो है ना मशवरा कैसे देते हैं। आपकी वजह से वो इल भी हो सकता है, आपकी वजह से वो जो है ना रमजान के रोजे भी छोड़ सकता है। हत्ता कि डॉक्टर की जो है ना, मैंने देखा कि जब वो उसको नसीहत करता है तो बहुत सारे लोगों की नसीहत को छोड़कर वो डॉक्टर की ही नसीहत मानता है, और फिर आखिर में ही डज नॉट वांट टू पुट टू डिफिकल्टीज, और अल्लाह आपको कभी भी जो है ना सख्त हालात में नहीं लाता है। तो ये आयत बार बार कोट हुई, ये डायरेक्टिव है, डायरेक्ट एक किस्म का, इसमें कोई शुबा नहीं है। इस्लाम हैज 1.5 बिलियन एडहेरेंट, अभी ये तादाद बढ़ गई है, इट इज नाउ 1.9, आई एम करेक्ट इफ नईम साहब, एंड 23% of the world population of 6.8 million, which is also now increased to 25%, और ये जो है ना 3% पर ईयर ग्रो कर रही है। तो शुक्र अल्हम्दुलिल्लाह हम मुसलमान ग्रो कर रहे हैं एज कंपेयर टू द अदर पीपल, अदर रिलीजन के लोग, लेकिन हमें जो है ना ट्रू मुसलमान होना चाहिए। और फास्टिंग जो है ना रमजान की, ये जो है ना ऑब्लिगेटरी है, मस्ट है। तो इसमें हमें जो है ना हेल्थी एडल्ट मुस्लिम को जो है ना वो हमारे लिए इम्पोर्टेंट है कि हम उनकी हेल्थ की जो है ना, और वो हम फिजिशियन ही है जो उनके दावेदार हो सकते हैं और उनके लिए काम कर सकते हैं। एपिडेमियोलॉजी ऑफ डायबिटीज एंड रमजान जो एपिडार स्टडी है, उसने 2001 में 42.8% और 78% ऑफ द पेशेंट विद टाइप 1 और टाइप 2 डायबिटीज मेलाइटस रिस्पेक्टिवली फास्टेड फॉर एटलीस्ट 15, यानी 15, इस स्टडी में जो है ना 15%, 42 एंड 78, फिर भी जो है ना 15 दिनों तक लोगों ने जो है ना रोजे रखे हुए हैं। तो इट्स एन इम्पॉर्टेंट स्टडी। और फिर उसके बाद क्रीड जो हमारी लाइफ टाइम मेंबरशिप रखते हैं, लाइफ टाइम जो है ना एग्जीक्यूटिव मेंबर है, इफ यू रिमेंबर जबार साहब, उनकी क्रीड स्टडी में उनकी जो है ना बहुत ज्यादा वो है, इसी में भी जो है ना यही परसेंटेज आपको जो है ना लगभग नजर आ रही है। लेकिन चूंकि इसमें जो है ना एजुकेशन इन्वॉल्व था, तो ये चीज जो है ना हाइपोग्लाइसीमिया की रिस्क कम होती जा रही है, लेकिन फिर भी जो है ना 63.6% रोजा रखा गया है। तो इट्स एन इम्पॉर्टेंट वन। अच्छा, क्या हो जाता है, क्यों मसले आ जाते हैं, क्या ऐसा फिजियोलॉजिकल चीज होती है जिसकी वजह से जो है ना रोजे में जो है ना हम थोड़ा बहुत डिफर करते हैं नॉर्मल फिजियोलॉजी से। तो यू कैन सी स्लीपिंग पैटर्न्स आर ऑफन अल्टर्ड ड्यूरिंग द रमजान, और सर्केडियन रिदम चेंज हो जाती है। वही सर्केडियन रिदम आपको जो है ना आपकी जो सब मॉलिक्यूलर लेवल पर बातें जानती है, कोर्टिसोल के लेवल को चेंज कर दे, और इसकी वजह से आप इल फील करते हैं, चेंजेस आ जाती हैं आपके पॉइंट में, और हमारे पठानों की तो बहुत ज्यादा आ जाती हैं। तो जब आप फास्ट कर रहे होते हैं तो उसकी वजह से रेजिस्टेंस और डेफिशिएंसी कैन लीड टू एक्सरसाइज ग्लाइकोजन ब्रेकडाउन एंड इंक्रीज ग्लूकोनियोजेंस इन द पेशेंट विद द डायबिटीज एज वेल एज कीटोजेनेस इन द पेशेंट विद टाइप 1 डायबिटीज। मैं आपको लंबे एलोगरिथम में नहीं लेकर जाऊंगा, लेकिन कुछ चीजें हैं जो मैं इंपॉर्टेंट स्लाइड्स के थ्रू आपको बताऊंगा। Muslims who fast during the Ramadan must abstain from eating, drinking, and use of oral medication, smoking from pre-dawn to almost sunset. However, there are no restriction on the food or fluid intake between the sunset and dawn. Many patients with diabetes insist on fasting during Ramadan, thereby creating a medical challenge for themselves and for their healthcare worker. Almost 11 cases जो है ना आतिफ ने दिखाए, वो सारे के सारे चैलेंजिंग थे हमारे लिए, और ये चैलेंज हमेशा आप ही के पास आती है, क्योंकि आप उनको कहते हैं कि यू हैव टू फास्ट और यू डोंट हैव टू फास्ट। तो चैलेंज आपके ऊपर आ जाती है। आप ऐसा, अगर आप प्रैक्टिसिंग मुस्लिम है तो आप खुद भी समझते हैं कि अगर मैं किसी को रोजे से रखता हूं तो दैट बर्डन्स कम्स ऑन यू। तो यहाँ पर आप लोगों ने यू हैव टू अंडरस्टैंड कि अब मैंने इस बंदे को जो है ना रोजा तोड़वाना है और इसका रोजा नहीं रखवाना है, तो ये आप पर भी एक जिम्मेदारी बनती है. It is important that the medical profession be aware of the potential risk associated with fasting during Ramadan and will approach to the mitigate those risks. From fasting to fat state, 3 levels में जो है ना फिजियोलॉजी आपकी जो है ना चलती है जब आप फास्टिंग शुरू कर देते हैं. फर्स्ट पोस्ट एब्जॉर्बिव फेज है जो 6 से 24 घंटे तक चलती है. उसमें जो है ना आपकी दूसरी ग्लूकोनियोजेनिक फेज शुरू हो जाती है और वो 2 से 10 डेज में जो है ना चलती रहती है. और इसके बाद जो है ना प्रोटीन कंजर्वेशन फेज है जो बियॉन्ड 10 डेज फास्टिंग के बाद शुरू हो जाती है. रिस्क बार बार हम बात कर रहे हैं रिस्क के, और हमारी सारी मैनेजमेंट, हमारी सारी जो है ना काविशें इसी रिस्क के इर्द गिर्द चलती है. अगर डायबिटिक पेशेंट को हमने मैनेज करना है तो हमने कौन कौन सी चीजों को जो है ना देखना है. तो वो है हाइपोग्लाइसीमिया, हाइपरग्लाइसीमिया, डायबिटिक कीटोएसिडोसिस और डिहाइड्रेशन, साथ में थ्रोम्बोसिस के. तो हमारी जो है ना सारी फोकस इन चीजों पर, जब हम पेशेंट को ट्रीट कर रहे होते हैं तो हम इन चीजों को अवॉइड करने की. और ये जो अभी आतिफ ने कहा कि 360 पेजेस का जो है ना डार का जो गाइडलाइंस है, ये सारा इसी 4 फैक्टर्स के इर्द गिर्द घूमता रहता है. तो व्हाट वी गो, ये पहली कैटेगराइजेशन है जिसको अभी 3 में कर दिया गया है, लेकिन मैं इसकी डिटेल में नहीं जाऊंगा. इट हैज बीन ऑलमोस्ट डेल्ट बाय डॉक्टर नईम, लेकिन स्टिल हमारा जो है ना ज्यादा वास्ता रोज के दरमियान या रमजान के दरमियान लो रिस्क वाले और मॉडरेट रिस्क वाले के बाकी को हमने स्ट्रेट फॉरवर्ड कहनी है कि नो, वी डोंट हैव टू गो फॉर फास्टिंग. आपकी जान छूट जाएगी. अगर वो फिर भी रखना चाहता है, फिर भी आपके साथ गाइडलाइंस हैं, फिर भी आप पेशेंट को मॉनिटर करोगे, फिर भी आप तरीके से जाओगे. ऐसा नहीं हो कि अगर वो जो है ना उसने कहा कि मैं करूंगा और आप कहेंगे कि नहीं नहीं फिर मैं आपको ट्रीट ही नहीं करूंगा. नो, यू विल हैव टू मेक, उसके लिए आपने जो है ना उसके लिए सेटिंग बनानी है. आपने उनको जो है ना इनकरेज करना है बार बार. उसने 2 रोजे रख दिया, 3 रोजे रख दिए, फिर उसको बुलाएं. उसके अटेंडेंस से जो है ना उनके जो नजदीकी लोग हैं, मुफ्ती की जो है ना जो हमारे दीनी स्कॉलर्स हैं, उनके थ्रू जो है ना कोशिश करें कि उनको बताते जाएं कि नहीं आपके लिए हैजर्डस है. तो इंशाल्लाह वो मान जाते हैं. 90% मैंने देखा है कि हमारे पेशेंट मान जाते हैं. ओके, क्वेश्चन. स्टूडेंट्स फाइनल ईयर के कितने हाथ उठा सकते हैं? पीजीज, पीजीज हाथ उठाएं. अब अच्छा ठीक, ओके. सो कैन ए डायबिटिक पेशेंट फास्ट ड्यूरिंग रमजान? ऑफ कोर्स, क्यों नहीं, ठीक है ना. और जितना भी लिटरेचर आया है उसमें जो है ना टाइप 2 जो पेशेंट है, मेजॉरिटी ऑफ टाइप 2 डायबिटिक पेशेंट है, वो प्रॉपर एजुकेशन और डायबिटिक मैनेजमेंट के साथ वो रोजा रख सकते हैं. अब फिजियोलॉजिकल स्टेट ऑफ डायबिटिक ड्यूरिंग रमजान, कार्बोहाइड्रेट के साथ मेजर प्रॉब्लम तो कार्बोहाइड्रेट से शुरू हो जाती है, फिर आगे जाती है फैट्स पर, उसके बाद जो है ना प्रोटीन वगैरह. लेकिन प्रोटीन के स्टेज तक जब ये पहुंचती है तो बहुत कुछ बिगाड़ चुकी होती है, ठीक है ना. तो दी फर्स्ट थिंग टू स्टार्ट विद इज कार्बोहाइड्रेट मेटाबॉलिज्म इन हेल्दी पर्सन. मोस्ट ऑफ द स्टडीज शोज कि अगर वो फास्टिंग नॉर्मल लोगों में कर दें तो वो 60 से 70 मिलीग्राम की जो है ना डेप्थ हो सकती है उसमें, इससे ज्यादा डेप्थ नहीं. लेकिन ये नॉर्मल के लिए, डायबिटिक्स के लिए नहीं है. चेंजेस इन सीरम ग्लूकोज में अकर इन इंडिविजुअल डिपेंडिंग अपॉन द फूड हैबिट्स एंड इंडिविजुअल डिफरेंसेस इन मेटाबॉलिज्म एंड एनर्जी रेगुलेशन. फिर यहाँ पर कोमॉर्बिड्स की चीजें आ जाती है. बॉडी वेट हमने ऑब्जर्व किया है कि नॉर्मल इंडिविजुअल में 2 to 3 kg वेट लॉस होता है. डायबिटिक में चूंकि मेडिकेशन प्रॉब्लम्स, यूजुअली ये वेट हम ऑब्जर्व नहीं, लेकिन फिर भी जो है ना बात स्टडी दिखाती है कि जो है ना वेट लॉस हो रहा है. वेरिएशन, ब्लड ग्लूकोज की वेरिएशन है. मोस्ट पेशेंट शो नो सिग्निफिकेंट चेंजेस इन देयर ग्लूकोज कंट्रोल. इन सम पेशेंट सीरम ग्लूकोज कंसंट्रेशन में फॉल और राइज, और यही कॉम्प्लिकेशन और यही रिस्क हम जो है ना एड्रेस करते हैं. और ये वेरिएशन में भी ड्यू टू द अमाउंट एंड टाइप ऑफ द food consumption, regularity of taking medication, engorging after the fast is broken, or decreased physical activities जो हमारी हो रही है उसकी वजह से हो रही होती है. HbA1c वैल्यू पर कोई इतना ज्यादा फर्क नहीं, लेकिन कुछ स्टडीज शो कर रही है कि डायबिटिक्स में थोड़ी बहुत जो है ना HbA1c रेज हो जाती है, नो इम्पोर्टेंस ऑफ इट। और इसी तरह सी पेप्टाइड है, फ्रक्टोजामीन है, उस पर भी ज्यादा कोई चेंजेस नहीं आती स्पेसिफिकली आफ्टर द रमजान फास्टिंग। हाँ वही बात है, लेकिन वो स्लाइड जो उसमें है दैट इज इंपॉर्टेंट फॉर यू पीपल। हाइपोग्लाइसीमिया की जो है ना ग्लूकोज रिलेटेड क्या प्रेजेंटेशन हो सकती है, अगर आपको कोई कि पेशेंट को समझाना चाहते हैं या खुद समझना चाहते हैं तो दैट स्लाइड इज फॉर यू। 90 से जब नीचे आ जाती है 75, 70 कहाँ पर जो है ना आपके रेगुलेटरी हार्मोन्स कहाँ पर शुरू हो जाते हैं और कहाँ किस टाइम तक रहते हैं। हम कहते हैं ना कि पोस्ट हाइपोग्लाइसेमिक इफेक्ट्स जो होते हैं उसी तरह जो है ना हाइपरग्लाइसीमिया को जो है ना इसी तरह रहते हैं वो बिकॉज ऑफ दीज हार्मोन्स। तो ये हार्मोन भी जो है ना एक्टिव रहते हैं इन रमजान। हाइपोग्लाइसीमिया बहुत सारी बातें इस पर हो गई। इट हैज बीन एस्टिमेटेड दैट हाइपोग्लाइसीमिया अकाउंट फॉर 2 to 4% ऑफ द मॉर्टेलिटी इन द पेशेंट विद टाइप 1 डायबिटीज एंड मच लेसर विद टाइप 2। फिर वही बात हमारी के टाइप 1 में जो है ना बहुत प्रॉब्लम होती है। यूजुअली वी डोंट आस्क देम टू गो फॉर फास्टिंग, लेकिन अगर वो फास्ट करते हैं तो दिस कैन हैपन। रिसेंट जो एपिडार स्टडी हुई है शो के फास्टिंग ड्यूरिंग रमजान इंक्रीजेस द रिस्क ऑफ सीवियर हाइपोग्लाइसीमिया 4.7 fold in patient with type 1 diabetes while 7.5 fold in patient with type 2 diabetes। इसी तरह हाइपरग्लाइसीमिया एपिडार स्टडी शो करती है कि 5 fold इंक्रीज होता है इन द इंसिडेंस ऑफ द सीवियर हाइपरग्लाइसीमिया और 3 fold इंक्रीज in the incidence of severe hyperglycemia with or without ketoacidosis in the patient with type 1 diabetes। Diabetic ketoacidosis very dreadful condition। जब भी हमें रमजान में कोई पेशेंट जो है ना डायबिटिक कीटोएसिडोसिस में आता है we are at trouble। एंडोक्राइन वार्ड की इमरजेंसी लग जाती है। फ्रॉम कंसल्टेंट टू हाउस ऑफिसर they are going to run। वैसे भी जो है ना डायबिटिक कीटोएसिडोसिस सबसे जो है ना एक ड्रेडफुल इमरजेंसी एंडोक्राइनोलॉजिस्ट और डायबिटोलॉजिस्ट के लिए होती है, लेकिन ड्यूरिंग रमजान इट इज वन ऑफ द ड्रेडफुल थिंग टू डील विद। Patient with diabetes who fast during Ramadan are at increased risk of development of diabetic ketoacidosis, particularly poorly controlled before Ramadan। वही बात the risk may further increase due to the excessive reduction of insulin dose based on the assumption that the food intake is reduced during the Ramadan। Dehydration, thrombosis, reports have suggested that there is increased incidence of the retinal vein occlusion। However, hospitalization due to a coronary event, which is also a sort of thrombosis, are not increased during Ramadan। ये studies हैं। Limitation of the fluid intake और साथ में जो है ना hyperglycemia पेशेंट को जो है ना डिस्पोज करती है टुवर्ड्स द थ्रोम्बोसिस एंड डिहाइड्रेशन। अगेन ये जो है ना अगर आप सारी जो है ना रिस्क फैक्टर्स को याद नहीं कर सकते हैं, ये चीजें आपके जहन में होनी चाहिए कि कुछ चीजें डायबिटीज रिलेटेड जो होती है जो ज्यादा रिस्क होती हैं और कुछ चीजें जो है ना डायबिटीज के साथ एसोसिएटेड जो होती हैं दैट कैन बी टेकन इनटू अकाउंट। और उसमें जो है ना नेफ्रोपैथी है, एडवांस सीवियर रेटिनोपैथी है, ऑटोनोमिक न्यूरोपैथी है, हाइपोग्लाइसेमिक अनअवेयरनेस है, साथ में जो है ना पूरली कंट्रोल्ड डायबिटीज है और मल्टीपल इंसुलिन इंजेक्शन जो लोग लगाते हैं वो भी जो है ना इस कंडीशन में आते हैं। और फिजियोलॉजिकल कंडीशन जो बहुत होती है प्रेगनेंसी एंड लैक्टेशन है। को एग्जिस्टिंग मेजर मेडिकल कंडीशन जिस तरह एक्यूट पेप्टिक अल्सर हो गया, सीवियर पल्मोनरी ट्यूबरकुलोसिस, सीवियर इन्फेक्शंस हो गए, ब्रोंकियल एस्थमा हो गया, सीवियर रिकरेंट स्टोन्स फॉर्मेशन है, कैंसर हो गए, ओवर्ट कार्डियोवास्कुलर डिजीज हो गई, सीवियर साइकेट्रिक कंडीशन हो गई, ये सारी की सारी एसोसिएट करती हैं हाई रिस्क के साथ। अब प्रिंसिपल्स क्या है प्री रमजान कंसल्टेशन, आप उसको क्या वो जो है ना वो देंगे, मशवरा देंगे पेशेंट को, क्या जो है ना आप कंसल्टेशन देंगे। फिजिकल वेलबींग असिस्टेंट उसकी पहले करेंगे, असेसमेंट ऑफ द मेटाबॉलिक कंट्रोल उसकी करेंगे, जिस तरह HbA1 जिस तरह प्रीवियस स्लाइड्स में आपको दिखाया गया है कि रीनल फंक्शंस हुए हैं, HbA1c हुआ है, उसकी जो है ना रिकॉर्ड्स आपने देख लिए हैं। पिछले साल वाले जो है ना डायबिटिक रिकॉर्ड आपने देखी है, रमजान में अगर उसने कोई रोजे रखे हुए हैं तो उसका रिकॉर्ड भी आपने, ये सारी जो है ना इस असेसमेंट मेटाबॉलिक कंट्रोल में है। और फिर उसके बाद एडजस्टमेंट ऑफ द डाइट प्रोटोकॉल फॉर द रमजान फास्टिंग, एडजस्टमेंट ऑफ द ड्रग रिजीम, वो हम आपको आगे स्लाइड में बताएंगे। एंड देन द एनकरेजमेंट ऑफ द कंटिन्यूड प्रॉपर फिजिकल एक्टिविटी। पेशेंट को आप ये नहीं कहेंगे कि बस आप बैठ जाएं, हाँ यस ड्यूरिंग द फास्टिंग, जब वो फास्ट कर रहा होता है उसमें जो है ना यू मेक हिम, yes you don't need to go for the rigorous physical activity, लेकिन आप उसको कह सकते हैं कि उसमें भी अगर नॉर्मल एक्टिविटी वो रख सकता है तो they can continue with recognition of the warning symptoms of dehydration। उनको जो है ना रिकॉग्नाइज होना चाहिए, जिस तरह हमने बात की कि हाइपोग्लाइसीमिया और अदर जो है ना पॉसिबल कॉम्प्लिकेशन, उन पेशेंट को आपने समझाना है कि ये हो सकता है, अगर आपको ये हो रहा है तो यू नीड टू कम एंड टू कंसल्ट अस। न्यूट्रिशन और ड्यूरिंग रमजान फास्टिंग, मेन वही न्यूट्रिशन रहेगी जो नॉर्मली होती है, बट थोड़ी बहुत जो है ना हाई फाइबर डाइट जो है ना आपने इंक्लूड करना है। रिफाइंड शुगर्स को आपने जितने भी कम कर सकते हैं उनको कोशिश करें कि रिफाइंड शुगर्स आप उनके कम करें। और दरमियान में जो वक्फा है बिटवीन दी अफ्तार और सहूर, उसमें दे कैन टेक स्मॉल स्नैक्स इफ, अगर पेशेंट को कोई तकलीफ है। और फिजिकल एक्टिविटी वी हैव ऑलरेडी सेड कि वो जो है नॉर्मल अपनी एक्टिविटी कर सकते हैं, बट नॉट रिगोरस एक्टिविटी ड्यूरिंग दी फास्टिंग। डार अलायंस की गाइडलाइंस है, अगर कोई तस्वीर लेना चाहते हैं तो देखें, और इसमें जो है ना बाकायदा न्यूट्रिशन पर बहुत बड़ी डिस्कशन है और यू कैन गो थ्रू इट, और मुख्तलिफ ज़ुबानों में मुख्तलिफ मुल्कों के लिए। वही बात है, ड्रग रिजीम एडजस्टमेंट है, डाइट कंट्रोल है, डेली एक्टिविटी एज आर द 3 पिलर्स, उसी तरीके से हमको जाना है। होम मैनेजमेंट किस तरह किस फैक्टर्स पर जो है ना कंसिस्ट होता है, तो उसमें मॉनिटरिंग जो है ना होम ब्लड ग्लूकोज होता है। नईम साहब ने आपको एक डायग्राम दिखाया जिसमें जो है ना आप 7 SMBGs कर सकते हैं, खुद को जो है ना मॉनिटर कर सकते हैं, ग्लूकोज को मॉनिटर कर सकते हैं। और वो इसलिए होता है कि आपको जो है ना अपने डॉक्टर के साथ जो है ना मशवरा करें कि उसको आप बताएं कि इसमें जो है ना मुझे ये आ रही है, तो आइदर आया वो आपकी डोज इंक्रीज करवा रहा है इंसुलिन का, या जो है ना कोई एसोसी, या जो है ना आपको समझा देगा कि नहीं इट्स ओके यू गो फाइन, और ये आपको बता देगा कि यू डोंट हैव टू गो फॉर द फास्टिंग। कीटोसिस के लिए आप चेक कर सकते हैं और बता सकते हैं कि कीटोसिस जो है ना चेक करें, आजकल स्ट्रिप मिल रही है। मेजरिंग डेली वेट इंफॉर्मेशन फिजिशियन को, और साथ में जो है ना डाइट की इनटेक के बारे में आप उनको जो है ना बता सकते हो और आपके साथ रेगुलर इन कांटेक्ट रह सकते हैं। एजुकेशन अबाउट वार्निंग सिम्टम्स, डिहाइड्रेशन, हाइपोग्लाइसीमिया, हाइपरग्लाइसीमिया के बारे में, एजुकेशन अबाउट ब्रेकिंग फास्ट एज सून एज एनी कॉम्प्लिकेशन और न्यू हार्मफुल कंडीशन। क्या 300 मिलीग्राम हमारा जो है ना कट ऑफ वैल्यू है कि अगर वो आता है और पेशेंट को हम जानते हैं कि उसके है प्रॉब्लम, तो हम उसको कह देते हैं गो फॉर इट, आप जो है ना फास्ट को खत्म कर सकते हैं, आप तोड़ सकते हैं रोजे को। और इसी तरह जो है ना अगर 70 से जो है नीचे आ गया तो देन यू कैन आल्सो टेल देम टू गो फॉर फास्ट, आप खत्म कर सकते हैं। और मस्ट बी डॉक्टर शुड बी ऑलवेज देयर फॉर असिस्टेंस, ठीक है ना। ये अगेन स्लाइड है, मैंने आपको कहा कि रिपीटिशंस होती रहेंगी, रिपीटिशन मेमोरी का एक हिस्सा है। यही चीजें हैं, यही जो है ना रमजान एजुकेशन, हमारे नईम साहब ने भी जो है ना इस पर डिस्कशन की, लेकिन ये जो है ना इसका में जिन लोगों ने एजुकेशन लिया स्पेसिफिकली प्री रमजान, उनकी हाइपोग्लाइसेमिक इवेंट्स कम हो गए, और ये जो है ना मुख्तलिफ इस स्टडी से जो है ना वाज़ेह है। यू कैन सी इट कि ये जो है ना एजुकेशन वाले लोग हैं और ये नॉन एजुकेशन वाले लोग हैं। ये रेड जो है ना ये रमजान, तो आप देख सकते हैं कि एजुकेशन की वजह से कितना रिडक्शन हो गया है एज कंपेयर टू द वन विद दैट बिग बार ऑफ रेड कलर। ट्रीटमेंट मैनेजमेंट, ये तो इट वाज अ बिट, अब ट्रीटमेंट मैनेजमेंट हम इसको जस्ट सिंप्लीफाई कर देते हैं, एक ही फ्लो चार्ट में मैं ले आता हूँ और इसको खत्म कर दें। बाकी स्लाइड्स हैं हमारे साथ, लेकिन वी विल गो थ्रू दैट। सेवरल इंपॉर्टेंट इश्यूज डिजर्व करता है स्पेशल अटेंशन, उसमें इंडिविजुअलाइजेशन, बार बार हम इंडिविजुअलाइजेशन की कहते हैं, हम एक्सपीरियंस की कहते हैं, यहाँ पर यही बात आ जाए। फ्रीक्वेंट मॉनिटरिंग है ग्लाइसीमिया की, न्यूट्रिशन की है, एक्सरसाइज की है, और फिर उसको बताना है कि आपने कब ब्रेकफास्ट करना है, ठीक है। ये स्लाइड सब उसकी जो है ना, ये फ्लो चार्ट है, ये ऑलमोस्ट मैनेजमेंट का जो है ना कुल स्टोरी है। अगर ये फ्लो चार्ट आपके जहन में आ गया और व्यवस्थित हो गया, तो यू डोंट नीड टू गो फॉर दी 305 जो है ना जो पेजेस हैं उसके डार्क गाइडलाइंस के। तो ये ऑलमोस्ट यू कैन सी इट। इसमें मैं जरा ये ओरल मेडिकेशन और इंसुलिन पर बात कर लेता हूँ, बाकी तो हमारी बातें हो गई है। थ्रू आतिफ मुनीर केसेस हमने कुछ ओरल मेडिकेशन के बारे में भी हमने बात कर ली, हमने कुछ इंसुलिन के बारे में भी बात कर ली। कॉमनली जो हमारे इस्तेमाल में होती है ओरल मेडिकेशन, वो सल्फोनाइल यूरिया है, मेटफॉर्मिन है, SGLT2 इनहिबिटर अभी जो है ना लास्ट 4-5 ईयर से जो है ना इंट्रोड्यूस हुई है। इसके साथ जो है ना अदर एसोसिएट पायोग्लिटाजोन है वगैरह वगैरह। तो इसमें कुछ चेंजेस लानी चाहिए और कुछ में जो है ना चेंजेस नहीं लाने चाहिए। वो चेंजेस क्या है, अगर कुछ BD डोज में ले रहे हैं तो उनको आप जो है ना जो मॉर्निंग वाली डोज थी उसको आप इफ्तार में ले आएंगे, और जो दूसरी वाली डोज है वो आप कोशिश करें कि उसको हाफ करके सहूर में ले आएं। तो ये जो है ना स्पेसिफिकली जो है ना जो सल्फोनाइल यूरिया के बारे में मैं कह रहा हूँ। और इसी तरह जो है ना इंसुलिन के बारे में, कि इंसुलिन अगर आप लगाना चाहते हैं, कुछ की जो है ना सिंगल डोज है, कुछ की जो है ना बाइफेजिक है, कुछ की जो है ना टिपिकल जो 4 डोजेस होते हैं, उनको आपने तरीके से मैनेज करना पड़ता है। तो अगेन कमिंग विथ, तो सर पहले जो है ना हम मेटफॉर्मिन की बात करते हैं। मेटफॉर्मिन आपने आतिफ मुनीर के स्लाइड्स में देखा होगा कि मेटफॉर्मिन को हमने कभी नहीं छेड़ा। इसी तरह है ना आतिफ, मेटफॉर्मिन को हमने छेड़ा ही नहीं, और उसको हमने उसी तरीके से बस वो डोजेज एडजस्टमेंट उसी तरह आ गई जिस तरह सुबह और शाम होती तो सहूर और अफ्तारी में आ गई। इसके बाद जो है ना सल्फोनाइल यूरिया है, वही बात कि उसकी जो है ना रिडक्शन अगर BD डोज में है तो रिडक्शन कराएं। रिडक्शन आप उसके टाइम पर करेंगे जब सहूर होगा, सहूर में आप जो है ना उसको हाफ रिडक्शन करा सकते हैं। फिर उसके बाद जो है ना डायपेप्टाइड जो है ना DPP-4 इनहिबिटर्स हैं, उनकी आपको कोई एडजस्टमेंट की जरूरत नहीं है, यू कैन कंटिन्यू ऑन विद इट। और इसके अलावा जो है ना पायोग्लिटाजोन है, डायोन्स, ये जो है ना you don't have to change, you continue it with the same। इसके बाद जो है ना कुछ हम नए ड्रग्स, जिस तरह SGLT2 पर हमारी बात हुई है, इसी तरह जो है ना हमारी ये GLP-1 एगोनिस्ट पर हमारी बात हुई। GLP-1 एगोनिस्ट या SGLT2 इनहिबिटर्स यूजुअली जो डेटा है हमारे साथ, कोई प्रॉब्लम नहीं है इनके साथ, लेकिन हाँ यू डोंट हैव टू इंट्रोड्यूस इट। आपने रोजे के इर्द गिर्द जो है ना उसको इंट्रोड्यूस नहीं करना है। और ये जो है ना इट वाज आल्सो शोन इन दी जो केसेस हमने की हैं, आतिफ ने जो केस, उसमें जो है ना हमने बार बार यही किया कि नई चीज आप लोगों ने नहीं इंट्रोड्यूस करें, पुरानों को आप मॉडिफाई करके उनको आगे जाने दें। तो दिस वाज अ बिट अबाउट द ड्रग्स। यही रिपीटिशन है, इसी के बारे में जो है ना बात हो रही है कि बेगोनाइट को किस तरह करेंगे, TCDs को, सल्फोनाइल यूरिया हो गए और इस तरह। तो ये सारी जो है ना रिपीटिशन है। हमारे साथ वक्त की ऑलमोस्ट कमी चल रही है, मैं देख रहा हूँ कि देयर इज सम ग्लूमी फेसेस, तो बस जल्दी वी आर फिनिशिंग विद इट इंशाल्लाह सून। ये कुछ स्टडीज हैं जिसमें टाइप 1 डायबिटीज में जो है ना हम मुख्तलिफ इंसुलिन की, लेकिन we'll just skip. It is safe to go with long acting insulin and then associatedly, लेकिन ये है कि it is again इसी तरह जो है ना वही बात हमारी फिर रिपीटिशन है। रिपीटिशन इस पर भी जो है ना आयशा शेख ने, मैम ने जो है ना बातें की हैं। तो आई थिंक लेकिन ये है कि टाइप 1 टाइप 2 और जेस्टेशनल में यूजुअली वी डोंट प्रेफर टू गो विद फास्टिंग, एंड दे शुड स्ट्रांगली बी एडवाइज नॉट टू फास्ट ड्यूरिंग द रमजान। दीज वुमेन का हाई रिस्क ऑफ, वो ऑलरेडी डिस्कस हुआ है तो हम इसको डिटेल में नहीं डिस्कस करेंगे। मॉनिटर ब्लड कर सकता है पेशेंट रमजान में? कोई फितवा तो नहीं है इसमें कि नहीं आप यू डोंट हैव टू प्रेक। अभी तो जो है ना फितवा ये भी आ गया कि यू कैन गो फॉर एन इंजेक्शन अगर जरूरत है हुई, लेकिन सबकुटेनियस में जो है ना फिर भी जो है ना प्लस माइनस में, लेकिन इसको हम एम्फेसाइज नहीं कर रहे हैं, बट यू कैन गो फॉर द मॉनिटरिंग ऑफ द ब्लड। यही बात कि ब्लड ग्लूकोज आप मॉनिटर कर सकते हैं, जब 70 से लो होगा तो आप कोशिश करेंगे कि उनको कहें कि रोजा तोड़ दें, अगर 300 से अबव आ रहा है तो उनको कह दें कि आप रोजा तोड़ दें, लेकिन वो भी सरकमस्टांशियल आपने देखना है, टाइम देखना है किस टाइम पर जो है ना आप उसको मॉनिटर कर रहे हैं। शुगर की मॉनिटरिंग की फिर वही बात है, जैसे 7 टाइम आप उसको जो है ना चक्कर से एक आपका उसमें है कि आप उसको जो है ना कभी भी कर सकते, बाकी जो है ना प्री सहूर है, पोस्ट सहूर है, मॉर्निंग में है, मिड उसमें है, आफ्टरनून में है और प्री इफ्तारी है, उसके बाद इसी तरीके से आप उसके चे जो है ना वो कर सकते हैं। Conclusion, I come to the slides of conclusion. So majority of the uncomplicated type 2 diabetic patient can last during the Ramadan safely. Pre-Ramadan medical assessment, education and motivations are very important to prevent diabetic related complications. Islam allows diabetics to have regular blood testing, and fasting along with regular prayer have been proved to aid in better control of diabetes. Again, individualization is important. And thank you very much. This is the picture of IBP, OPD of Hyderabad Medical Complex. Thank you.
Thank you so much. Now, our